hearing of the Senate Community Affairs Legislation Committee's inquiry into the Aged Care Bill 2024 provisions. I begin by acknowledging the traditional custodians of the land on which we meet today and pay my respects to their elders past and present, and I extend that respect to any Aboriginal and Torres Strait Islander people joining us today. The committee will be conducting today's hearing via teleconference and in person. My name is Senator Marielle Smith. I'm the chair of this committee, and I have with me today Senator Ruston in person and Senators Allman Payne, Kovacic and Pratt joining via teleconference. These are public proceedings being audio streamed live via the Parliament's website, and a Hansard transcript is being made. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. Witnesses also have a right to request to be heard in camera. If a witness objects to answering a question, they should state the ground upon which the objection is made, and the committee will determine whether it will insist on an answer having regard to the ground which is claimed. If the committee determines to insist on an answer, a witness may request that that answer be given in camera. I now welcome representatives from Helping Hand Port Lincoln and Edenfield Family Care. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, could I ask you please to state your full names and the capacity in which you're appearing today, and we'll start in the room with Mr Stewart.
Thank you. Chris Stewart, Chief Executive of Helping Hand Aged Care.
Thank you. And Ms Shapelius?
Michelle Shapelius, Operations Manager at Edenfield Family Care.
Thank you. And do either of you have opening statements you wish to make? Yes, Mr Stewart, please proceed.
Thank you. Thank you for the opportunity to appear before the committee today to discuss the Aged Care Bill 2024. My name is Chris Stewart, Chief Executive of Helping Hand Aged Care, a South Australian not-for-profit organisation and a part of the Uniting Care Australia network. Uniting Care collectively supports 100,000 older Australians, and we believe that every person should experience compassion, dignity and respect as they age. Our vision is for an aged care system that is future-proofed, addressing the needs of older Australians and their families while ensuring sustainability. On balance, Helping Hand supports the Aged Care Bill in its current form, and we urge the government to release the accompanying rules as a matter of priority so the full implications of the bill can be understood. Helping Hand Aged Care has been serving older Australians since 1953, and today we care for over 4,000 people in residential and home care. We employ 2,200 staff, and with over a third of our operations in regional South Australia, we are one of the largest providers of aged care services in these areas. Our deep commitment to thin markets is rooted in understanding their essential role in allowing older people to age in their communities while maintaining local workforces. One recent example of our commitment to regional communities occurred in 2021, when Helping Hand helped to save the only aged care service in Whyalla, a town of some 20,000 people about 250 kilometres north of here. The service provider was community owned and had unfortunately faced regulatory sanctions, care failures and financial distress. 150 older residents, 200 in-home care clients and over 220 jobs were at risk. Through the support of the government and the hard work of our team, Helping Hand stepped in and successfully turned the service around, and today it is fully compliant, continues to serve the people of Whyalla and sustains those vital jobs. This success was achieved despite ongoing challenges that regional providers face, including increased costs of compliance and regulation, workforce shortages, especially RNs, and the higher cost of operating in non-metro areas. We believe it's critical that the legislation and its accompanying rules and policies acknowledges the distinct challenges faced by rural, regional and remote providers to ensure that they can continue to deliver high-quality care. As one final point, I would like to highlight to the committee that Helping Hand has been active in co-designing sector readiness training materials, particularly to support trauma-aware and healing-informed care as outlined in the bill. This is especially important for the cohort of forgotten Australians whom I would like to acknowledge here today. In closing, I reaffirm our support for the bill and urge the Parliament to finalise and pass the legislation. Thank you very much. I look forward to your questions.
Thank you, Mr Stewart. And Ms Shapelius, did you have an opening statement you wish to make?
Yes, so Edenfield Family Care is a family-owned operation. They purchased the two facilities in Port Augusta in the early 2020s. So two facilities up there provide places for over 100 Port Augusta residents. and we employ over 100 staff in Port Augusta. And we welcome the opportunity to speak today, but we are disappointed that it's occurred a little bit late in the parliamentary term and still lacks some critical detail, much of which are informed that we'll address in subordinate legislation. And we are excited, though, that it's a resident-based approach of the Act. We are concerned, though, that it does require a major overhaul of our policies and procedures. And being a smaller organisation, this does rely quite heavily on one or two additional people with exceptional experience and knowledge through legislation. Thank you.
Thank you very much. I might kick us off with a few questions and then I'll pass to Senator Ruston, and if other senators can just advise me if they are seeking the call as well. But Mr Stewart, you spoke in your opening statement about the importance of being able to age in your local community. In South Australia, we know, there's often very big distances between our communities in regional South Australia. It's our population is much more dispersed than other states and territories. So could you expand on that point a bit for me? What does it mean for the people in your care to be close to home, and I guess a bit of more context about what that service delivery looks like in regional SA?
It is certainly different in regional, there's no doubt about it, and every community is different too. I would sort of add that as a comment, whether we operate in Jamestown, in Port Pirie, in Clare, in Whyalla, with residential care homes, and then we have home care services that go all over the place. So every community is different, and if I give the Whyalla example, one of their homes, they had 3 homes, and one of those homes had to close just before we came in. And that was devastating. 50 people had to be relocated. Some of them had to go either to Port Augusta or to Adelaide. It was very, very disruptive, and the community was quite rightly extremely upset when that happened. So we took on that role as a key enabler, I guess, to allow folks to stay in their own homes. And the community sentiment and the ability to work together with that community has been a really important factor of us keeping those services going in regional South Australia. So, and it's a very different relationship. They often know each other. So the people that work in the home will actually know the families of the people living in the home, the older people living in the home, and equally in home care, the rapport and the connection is, from what I can see, a lot stronger in regional communities because there's that close-knit relationship. So I think, I will leave it there. Yeah.
Okay. And can I ask for your perspective on support at home and the importance of that program? This bill sort of provides an architecture for that, but the importance of that program in regional South Australia.
Yeah, it's incredibly important. Main reason being is that there is a shortage of residential aged care beds in the regions. We've seen a lot of regional homes close over the last few years. We ourselves have had to close some beds because of short staffing, and I'm aware of other homes that have closed quietly. So therefore, support at home has to be a success in regional areas because people have got nowhere to go. So it's an incredibly important program. We want to see it work. We think the foundations are really strong, and we actually quite like the program of support at home. Just want to make sure that it's implemented and implemented correctly, so that older people can receive those services in their home.
And are there specific challenges that you've identified in relation to the successful delivery of support at home?
It's the costs, I would say. So the cost of delivering services in the regions is obviously a lot more than what it is in metropolitan cities. Longer distances. As a not-for-profit organisation, we are very conscious of not wanting to eat into people's packages by charging them significant amount for travel and mileage. So we sort of absorb a fair bit of that. So we're really hopeful that the IHACPA studies into and recognising the extensive costs of providing services in regional support at home are recognised and appropriately funded. And as I outlined in the submission by Helping Hand, we are concerned that if that's not done properly, then some of the viability and sustainability of those programs is certainly at risk.
Mm-hmm. Can I ask about the impact of the increased pay for aged care workers on recruitment and retention in your experience?
Yep. We have found that to be the increase in pay rates has been really welcomed and has had a positive impact on our business. If I look back at 2019, we had a turnover rate of around 20%. That went up to over 35% during COVID and post-COVID, when it was obviously very challenging, and now we're back into the low 20s. We think that the ability to both attract and retain staff has been improved through the wage increases. Doesn't take away from the challenges of finding staff in the regions, especially registered nurses.
Okay, thank you, Mr. Stewart. I might just pass some questions to Ms. Shapelius now on the telephone. Ms. Shapelius, this bill and the work surrounding it aims to deliver a more sustainable funding model for aged care. Can I understand how that impacts you and the delivery of your services?
Just mostly for us, it's retaining staff, and also finding staff in Port Augusta is quite difficult. So we are doing a sponsorship program, particularly for our registered nurses. However, that also has concerns for us because it is a 4 to 5 month wait time for that. So planning for your workforce can be quite difficult. It is quite an expensive situation to be in. The other thing that we are concerned about is the ability to house staff. So we're having to find accommodation for them, and it is quite difficult in regional areas. And attracting people to a regional area has also got their concerns.
Did you find the impact of the wage increase for aged care workers to be positive on your recruitment and retention of staff?
Definitely for our personal care workers we did. However, we did find that it had a negative impact to our registered nurses, who then requested more additional wage increases. So we're talking about being on the Nurses Award, where their level should be at a pay point 1, but they were actually requesting pay point 8. So maintaining and being able to keep their efforts and their knowledge, and we found that to be the opposite advantage for our registered nurses.
Right, okay. And can I ask, you said in your opening statement that you welcomed the residence-based approach to these reforms. Can you just expand on that a bit more for us and explain why you think that's important?
So I've been in aged care for over 20 years in executive level. For me, the current Aged Care Act is very provider-based. The new legislation identifies some excellent models for providers to listen to our residents and to our older people and what they need to and what they're expecting from us. And for me, that's from a registered nurse point of view, that's exactly what we need to be looking for, and to listen to our older people and what they need.
Thank you. And you mentioned you've been working in aged care for over 20 years. Can I ask what your experience has been in the sector and since the Royal Commission's final report, and if it's changed at all, or your reflections on the changes in the sector?
So I've been a registered nurse for over 20 years. And in aged care, I've worked in the acute sector as well. However, the aged care sector has been my passion. The changes that have come through since the Royal Commission have been very welcomed from myself and from the organisation, mostly because it's looking at making sure that our care and our services that we provide are of high quality and evidence-based practice. Some of those key changes have been that code of conduct that we can use for monitoring and management of staff, but it's also a key for the industry to be proud of when we are talking about aged care and what we do for our residents.
And Ms. Shapelius, you mentioned in your opening statement as well that you were disappointed in the delays to this legislation being brought to the Parliament. Can you tell us why you believe it's so important that these changes and this bill goes through and progresses quickly?
Yeah, absolutely. So I think it's the tight timeframes for me that we face. I'm concerned about the scrutiny that's going to be sufficient through the bill, particularly around some of the instruments potentially leading to unintended consequences. I mean, I do this from a personal experience with the NDIS. So I have a significantly disabled child, and the introduction of the NDIS was quite hasty, and it still remains quite unsettled. And we can see that through the legislation amendments. But from a personal point, the NDIS was rushed, and as someone that uses the NDIS, I don't want that to happen with the aged care bill as well.
Thank you, Ms. Chappellius. I'm going to pass the call to Senator Ruston now. Senator Ruston.
Thank you very much, and thank you to you both for being here. Can I perhaps start with you, Mr. Stewart? And in just to get an understanding from the practical perspective around, particularly around the regulatory impact of the changes, and I acknowledge that there's been a lot of reform and a lot of changes that have occurred in the aged care sector over the last number of years. So, do you have an estimation of what the regulatory cost would be on Helping Hand?
Thank you, Senator. So, if we consider the Royal Commission and the new standards that came in 2019, it's required a significant response from providers around governance, around quality of care, around implementation. So I can look at the experience that we had over the last few years, and I, conservatively, in terms of improving our board governance, improving our quality systems, I conservatively put that at least $2 million per annum. As I look forward to the changes that are coming through with support at home and others, the main cost is going to be in our systems upgrade. So our systems are not fit for purpose, and they will not cope with the reform. So we've been developing a business case that's sort of in the vicinity of $6 to $8 million to replace our systems that will be able to cope. In addition, I think the main impact is going to be a lot of staff training. So it's significant costs. I can't put a price on that, but we are having to pay people obviously to be trained on the new rights approach, the new standards, and all of the other elements that go with a significant regulatory changes to what we're about to see. So it is significant investment that's required. So yeah, the system costs that you have to do that as part of upgrading your business and ensuring the business, but the ongoing training and development of your staff are real costs and ongoing costs of compliance through improved governance.
Yep. Can I perhaps ask the same question of you, Ms. Chappellius?
Yeah, absolutely. So we have looked at the same. We're going to need an education module that meets the requirements of the new legislation that's coming through. Our systems as well wouldn't meet the requirements that are coming in, and our policies and processes will need to be completely rehauled. Now, being a smaller provider, the cost isn't quite as great. However, it still is looking like we're going to need to employ 2 to 3 full-time equivalent, exceptionally knowledgeable registered nurses with the ability to look at all of the evidence and put into evidence-based practice. So that's quite a significant cost for a small provider.
Yep. So in terms of the two main sort of additional requirements, upgrading of IT systems and staff training. So back to you, Mr. Stewart. What sort of time frame? Well, so first question, do you have enough information before you at the moment, in the absence of the rules, to actually understand what is required of you in relation to your systems upgrades and your staff training?
I would say no, not at the moment. There's been a lot of, if I talk about support at home, there's been a lot of information that's been coming out, and it does appear to be quite complex in terms of the new package levels and the co-contributions and the different levels of subsidisation that you might be receiving dependent on what type of service that you're receiving. It's actually a real matrix of complexity. So I don't think anyone's quite got that sorted out yet, but suffice to say that software providers are going to need a lot of time to actually build the rules, to recognise what comes through, the software rules, and then we've got to understand it and train our staff. So from a time frame perspective, it's extensive, I would have thought.
So to that end, if bearing in mind that some of the rules may appear not to be available until sort of February or so, and we know that the IHAC costing study is not likely to come back with anything much before that time. So if we just make the assumption that we're talking sort of, end of Q1 next year, maybe early Q2, how long do you think you would need to be able to get your systems in place to be able to implement this in a way that is, you can be reasonably sure you're not going to impact on the care that you're delivering to older Australians? And I'm happy for you to take that in terms of RAC and the new support at home. Do you think, what do you think the timeframes on both of those are?
It's extensive. It's at least 6 to 12 months. I mean, based on experience of when we roll out a new system, by the time you've trained everyone, understood it yourself, built in the proper policies and procedures, as Ms. Chappellis alluded to, these are significant undertakings. So I would say at least 6 to 12 months of some sort of parallel process or a pilot scheme, I think, would be tremendously valuable and ensure that, we're not making mistakes that we then have to go and rectify with the clients down the track. So that's the impact, that's the unintended consequences. Sometimes rushing stuff through, you realise you've made a mistake and then you have to go and fix it up, which is problematic.
So is the same sort of level of time required for the changes that are proposed for RAC as for support at home, or do you think there is a greater lead time is going to be needed?
I think the greater lead time will be in the support at home. I think RAC's reasonably well established. I mean, there's some pricing changes and changes with the co-contributions, but the complexity there will be in the grandfathering. So actually getting our heads around the grandfathering, explaining it to all of our admissions staff, educating the clients and their families about what's changed and understanding who's in which category, and then implementing the systems to support. So again, I'm sort of, hard to say, I'm thinking at least sort of 6 months in terms of a transition time frame for that, from the time we understand what it is to the actually going live with it.
Sure. Ms. Chappellis, have you got a view on that question?
Yeah, all of the information that we're getting, a lot of it is we think it looks like this, which is not terribly helpful as far as moving forward and trying to put into practice of what we're doing. We're looking at least a 12-month ability to have this rolled out properly. Small providers will really struggle with this because we don't have the services and the availability of staff to focus on this project. We still have our day-to-day things that we need to do. So from a smaller provider, that does concern me about the abilities of the small providers to be able to roll this out properly.
Sure. So I suppose the obvious question here, I mean, do you think there is a risk associated with rushing to have particularly support at home in place by the 1st of July? Do you think it is a reasonable time frame in which to ask you to do this?
I think that the framework for support at home is good. Like, all the foundations are there. But if there's some way that we could perhaps run it in parallel, especially around the pricing, that's the thing that concerns us a lot, is how are we going to get really robust, accurate pricing. That takes a long time to get right. They're certainly getting closer in residential care, but in home care, we're only doing we were part of the pilot study 2 years ago, and now they've just started the second study. So it does seem it's very complex, and it's a lot of work to understand how all these unit prices are going to work. Look, we've at least got the service list now, which we like, and we are quite keen to see the prices come out. But there is a risk that it gets rushed, as I said in my opening statement, and that the prices get wrong, and then we're unsustainable. That's the real risk as I see it.
Sure. Ms. Chappellis, I should have perhaps asked, does Enfield Family Care do home care as well as your 3 residential care facilities?
No, we're just residential.
Just resident. So on the basis of the changes that are proposed in terms of residential care, you made the comment that you thought 12 months was going to be necessary. What do you think the risks are if you're required to start on the 1st of July 2025 to your ability to actually deliver on the new requirements of the Act?
The risk for us is the information that will be delayed and not coming out until quite close to July next year. If that information is delayed and we don't have the ability to manage that, that would be because those pieces of legislation will be incorrect when we do it, or we just won't have the ability to implement it by that time.
So one of our people who submitted actually suggested that instead of moving to the new pricing, actually to operate in sort of like a shadow pricing type environment. Do you, either of you, I'll start with you, Mr. Stewart, think that would there be some value in running a shadow pricing for the home care, whilst we were trying to get more robust data around what should be the ongoing pricing, efficient pricing?
I don't have a lot of experience in that, Senator. So yeah, it's hard for me to comment, but I think the more pilots and stress testing that we can apply to the pricing structures and the models would be better. It's all the ability for the actual software providers to get their systems sorted so that we can actually, press the button and start it.
Yeah, sure. Can I now just ask you, you made comment in your submission in relation to the change from the caps on care management fees, going from 20% down to 10%. I mean, first thing, has the government consulted with you at all about the change on those caps? Do you have any insight into what the decision making was behind the move from 20 to 10?
Senator, Helping Hand wasn't consulted, but we're just one provider out of many. But when we did see the 10%, we were quite surprised. There was sort of no inkling that was going to be reduced so significantly, and is of great concern to us. And I think really, unless it's somehow captured in the unit pricing of the services, then I think there is an enormous undervaluing of the role that care management plays in our system.
One of the things that you often hear from consumers is the lack of transparency around the pricing. Do you have a view as to whether the changes that are being proposed here are going to provide greater transparency for older Australians on packages to be able to see what's being spent, or is that something that's still we are waiting on the rules to get some more clarity?
Well, I think the initial service lists that have been announced are pretty specific and itemising almost every element. So I think there'll be a lot of transparency, which I think will be a good thing. We haven't had any issues really with transparency. I mean, we've been audited by the Commission, and that's all been okay from our perspective. So, yeah, I would expect that that should still be maintained. I would hope that it would be maintained under a new system. Yeah.
Sure. You also mentioned around the challenges of thin markets, and Ms. Chappellius, I'm sure you're going to have a view on this as well, not just where you are now, but where you previously were, around how we end up with greater certainty for rural, regional, and remote areas. You raised the issue around the $600 million uplift in support at home proposed over the short term. But, I mean, I suppose the question is there a mechanism by which you think you could get greater certainty for your operations in rural, regional, remote, or, modified Monash outside of the cities, instead of actually always constantly having to rely on grant funding? And that goes in terms of, like, we've got this 2-year supplement that's put on the table at the moment for support at home, but equally when it comes to ACAP, everybody has to go cap in hand to the government every time you want investment into capital investment. Do you think, well, first of all, do you think that the currently the modified Monash system is adequately recognising the challenges of shallow markets?
Thank you, Senator. We were pleased to see the additional loading come in for the ANAC pricing just recently based on the Triple M classifications. I think that had been a real gap in the past, and that uplift will certainly help and we've calculated it out, and that sort of almost covers all of our additional agency costs that we're incurring at the moment for regional and rural. In support at home, again, we defer to IHACPA, but a similar model sounds sensible if there could be some sort of loading against those Triple M locations. The thin market grant that you allude to, again, came as a surprise, and to be honest, a bit disappointing. And because the way it's written and the information we have at hand sort of makes us as providers have to go and justify that we've incurred these extra expenses in order to qualify for what is both a competitive process and a time-limited process. That does not lead to sustainable outcomes where providers, providers can actually plan things out and implement systems for longer than 2 years with no guarantee of security. And now that directly impacts people in regions and rural areas.
Yeah, sure. Ms. Chapelius?
So I have great concern about the model from in-field family care, but also from a previous organisation that I was with. I don't think it understands quite the severity of reducing a regional facility, and through that Monash identification we had an organisation that met all of the requirements to be a regional facility. However, it was not identified as such. It was changed recently. The Port Augusta is not identified as a regional area because of the amount of population that are there. And that has significant impacts on the ability to go for grants, but it also has impacts on our financial viability as well. When we look at what services are available and the distance from the metropolitan Adelaide, it's a 3.5-hour drive from metropolitan Adelaide. Now, that's quite a significant distance for someone to go to, and it has complications to that too. So I have great concerns about the Monash model.
Thank you.
I might just rotate to a couple of other senators and then we can return if there's time. So Senator Pratt has a couple of questions, and then I think Senator Kovacic, both via teleconference. So Senator Pratt.
Thank you, Chair. I'm interested in learning from you both as providers about the experience of trying to raise capital and the extent to which reforms that are focused on the capacity to deliver more beds if required in response to the regional communities you work with.
I'm happy to start, Senator.
Thank you.
It is definitely more expensive in regional areas to build. I can give an example with the Whyalla operations that we took over, as I mentioned in my statement. That home, pardon me, one of the homes is really aged. There's you've got 6 or 8 people sharing a toilet down the corridor. They're in shared rooms, and so we worked with government to see if we could get a grant to help turn those into singles with en-suites to give people more dignity and more risk, as is outlined in the bill around statement of rights and a safe place to live. Yes. So we're only adding, as part of that development, we're only adding another 8 beds. That's going to cost $17 million, right? So that is a huge investment required just to increase capacity by a little bit. So the cost of, I think you would have heard that the cost of building new aged care beds is sort of $450 to $500. I think there's, and we know for a fact that there's a 15 to 30% premium on regional loadings for building. So very and then your RADs are much less in regional areas, significantly less in regional areas. There's just not the generally not the capacity. I speak generally not the capacity to pay in regional areas. So raising capital to invest into regional homes is a challenge.
Thank you for that answer. And I just also wanted to ask with respect to the commencement dates. I know Senator Ruston has asked you some questions in relation to this, but I'm keen to see how government can support the kinds of timelines that you need to see and to properly implement the legislation. So in that context, it could be transition phases in the regulations, for example. What would you like to see there?
It's hard to be specific on exactly what we want to transition at certain periods, but certainly keen to see the bill go forward. There's some really good elements in it, I think. But the transition just needs to be sort of staged out a little bit more, especially around, as we've already talked about at length, about the pricing. I think that's sort of, support at home, that's probably 6 to 12 months. I think the concept around supported residents, supporters and representatives, that needs a lot more planning. That's probably a 12-month process, I would say, because that is very complex going across state boundaries. And the workforce training and other implications for workforce actually understanding their new obligations in relation to things like whistleblowers and even just person-centred care. There's going to be some significant cultural changes there. So again, I think that's an evolving process that could take up to 12 months. So staging, I think the Act coming in is good, sets the foundation, but the actual start of some of the elements out of it can actually be staged out really sensibly. That will lead to a much more improved outcome.
Thank you, and thank you, Chair.
Thank you, Senator Pratt. Senator Kovacic.
Thank you, and thank you both for your evidence. My question relates to some of the comments made about, generally being in support of changes and then being necessary, but also just concerns about implementation and unintended consequences and some parallels to the NDIS. If each of you could sort of point out to me, what your primary concerns are around anything in perhaps the rules or information that we don't yet have that would be something that would effectively keep you up at night, that would be a massive problem for you to deal with or to implement, particularly as it relates to being in a remote or regional community.
Do you want to go first, Michelle?
Yeah, I'm happy to respond to that. Thank you. My concerns around the supporters and substitute decision maker, I think there's a lot of information that needs to go to the broader community around what that means for them. We also need to understand it quite clearly where there's differences between each state. That does keep me up at night, is keeping me up at the moment, thank you. The other thing that has concerns for me is the quality care worker voice body. I think that there's some double handling there, and that needs to be clarified and reviewed, as we already have that through the quality care advisory body, where we do have representatives of staff and key personnel.
Thank you.
What keeps me up at night at the moment is probably the hard legislation that's in the bill at the moment around 24/7 registered nurse compliance. That's an extremely difficult thing to achieve in some of our homes. And we understand that we've been trying to work towards that over a number of years, well, a year since that particular piece of legislation was passed. But now to sort of see it in the bill, where we'll be operating, unfortunately illegally for reasons outside of our control, at times, really needs to be considered carefully, because your registered nurses are very, very hard to get in some towns and very expensive to support through agency and flying them over.
And then the additional, challenge of when you actually do get them, then you don't have anywhere for them to live.
Yeah, exactly. We're fortunate in Whyalla. We've got some accommodation, an old aged care home that we've converted that we use for agency. But you're paying a premium of between 10 and 50% for agency, plus your flights, accommodation, meals, etc., etc., etc. So it is to maintain that, and we do that in certain areas, but in areas like Jamestown and Clare, it's actually hard to get the agency to even go there. So we have to rely on a very different model there that's been stress tested by the Commission. But it's still a target when you've got 4,000 nurses short based on the government's own data that we've legislated to have 24/7 nursing in place. It just, yes, it's an aspiration. Yes, we all want nurses in nursing homes, but there's different models, and I think more flexibility in the regional areas is something worthy of consideration.
Thank you. And thank you. That's it from me, Chair.
Thank you very much, Senator Kovacic. That concludes our... Oh, 1 minute. If you want an extra one. Sorry.
I was only going to my favourite question I ask everybody, and if you haven't got time to answer it now because we're out of time, I'm just really keen to understand the ratio in your homes of RAD, DAP and supported, and also do you know the cost of a bed in each of your facilities?
Michelle, do you want to go?
That was a good handball.
I've got it.
Anybody who's been listening knows I asked this question.
I can answer the supported ratio. We're sitting around the 70% for the two facilities in Port Augusta.
I couldn't pick up that number. Can you say that again, Michelle?
70% roughly.
Of supported?
Correct, yes.
Okay, and of the 30%, what's the ratio, DAP-RAD?
It would be sitting between 10 to 15% of the RAD.
Okay. And so is that 15% of the remaining 30%, or is that 15% of the total amount? So have you got 15% RAD and 15% DAP, or?
Correct, yes.
Yep, okay. No problem. And I'd just be really interested if you understood what the cost of a bed was to you, in the sense of if you actually applied the RAD, DAP and supported payments, whether the actual cost of operating that room, whether depreciation, cost of capital, maintenance, etc., do you know what that would be per bed in each of your three facilities?
No, I couldn't answer that.
Okay, what about you, Mr. Stewart?
Thank you, Senator. In relation to your first question, our supported residents are 64% in regional, 48% in metropolitan locations. Those residents who are paying a RAD only, 15% in regional, 24% in metro. A combination RAD DAP, 20% regional, 27% metro. In terms of a cost of a room, having heard your question prior to every other witness, Senator, I've tried really hard to answer that question and I end up in a burrow where I can't. All I can do is refer back to the government data that says it's about $44 plus administration. So $44 based on FY23 from the aged care financial report is what it costs to run a room, plus say $15, $20 for administration. Their depreciation rate is far too low. And so, yeah, I think it's well above the $69 per day that's been currently funded.
And obviously the cost of capital was going to vary significantly. So final question, is the amount that you're receiving, obviously you're receiving the higher amount of supported accommodation payments, does that cover the cost of these rooms? Bearing in mind you've just got $70 million to upgrade the Whyalla, absolutely needed. But clearly there was no way in the world that you would have been able to achieve that on the operational aspects, which this accommodation payment is supposed to do. So is the supported accommodation payment sufficient for you to operate in these markets that you operate in, to be able to reinvest?
No, Senator, it's miles away. I mean, we use our metropolitan homes cross-subsidise the regional homes. I mean, that's one of the, that's just a reality. And the RAD retention that's proposed in the bill is a good start, don't get me wrong, but in Whyalla, for example, the total RAD pool was about $4 million in 100 beds. I mean, it's just not, it's not going to get there. So, yeah, there's a fair way to go, I think. And I have no issue also with metropolitan. We're fortunate. We're not a standalone single provider, but if we could use our metropolitan homes without the constraints of potentially you know what? I'm going to stop there. Given the interest of time, I'll stop there.
I understand what you're saying. Thank you very much. I appreciate it, and thank you both. That was very helpful.
Thank you, Mr Stewart and Ms Shapelius, for providing evidence to our committee today. I don't believe you took questions on notice, but in case I missed one, we're asking for them to be returned to us by close of business on the 21st of October. You're free to depart, and thank you again for joining us. And I'll now call representatives from Matthew Flinders Care Services and the Eyre Peninsula Old Folks Home. I believe we're attending in person, and we can have them at the table. Thank you. And just to advise those in the room, we're no longer hearing from West Coast Home Care.
Oh. Hey, Drew, how are you?
Okay. Great. Well,
Trevor, so the water for the lady. Thanks.
Well, thank you both for appearing before our committee today. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, I'd like to ask each of you to state your full names for the capacity in which you're appearing. So, Mr Johnson, we'll start with you.
Okay, my name is Trevor Johnson. I'm the Chief Executive Officer of the Eyre Peninsula Old Folks Home, also trading as Pioneer Village, which is the location.
Thank you. And Ms Meredith.
My name is Nikki Meredith, and I'm the CEO of Matthew Flinders Home in Port Lincoln.
Thank you both. Do either of you have an opening statement you wish to make?
If you can go first.
Ms Meredith.
Thank you. Thank you for the opportunity to answer some questions and being able to speak about the new aged care bill. Matthew Flinders Home is a not-for-profit. We started in 1981, and we provide residential care, home care and CHSP services to our community. We certainly support the new aged care bill being introduced, and we certainly support a rights-based approach to aged care. There are certainly a couple of issues that we are concerned about that we would like to raise as part of this inquiry as well. Namely, implementation timeframes. We are concerned about the implementation, or what the implementation timeframes will look like, and we're concerned about their impact on workforce and legislation mandating the care minutes for RNs and care staff as well. Thank you.
Thank you, Ms Meredith. Mr Johnson.
Also, thank you very much for the opportunity to speak today. We support the bill. There's no question about that. There's a lot of change needed, and it'll help with that. It's the pace of change we're concerned about. We're also not-for-profit, and we like to call our consumers residents, because it's a home that they live in. They're just not consuming services from us. We do also continually strive to improve our offering, not just be compliant. The pace of change must be reasonable and not adversely impact on our ability to deliver for our residents, and we must balance rights with responsibilities. So let's give them rights, but let's give them responsibilities that go with those, please. Please don't pass the bill just to be politically expedient. We've already been hit by the fact that the government rushed in the 24/7 and other RN care minute mandates, and look at the consequences. You've had facilities closed across the country, and we reduced our capacity by up at least 10% for a period of time. Because there's only two ways to do that ratio. You either reduce the number of people you're servicing, or you get more nurses. If you can't get more nurses, you've got to reduce the number of people to make that ratio a bit easier to manage. In our submission, which I emailed through this morning and a copy has been provided, since July 23, we've actually met the mandated 24/7 coverage except for 2 shifts. The very first day and about 2 weeks ago. So it's cost us, though. It's cost us $888,000 at least net, and it's in the submission, to do that. Now, we were in a relatively lucky position that over the years, the board has been careful. They were saving up money to do major refurbishments to the facility. We've now had to use that money to help fund the RN mandate stuff. Every resource we divert to an unreasonable rate of change reduces our ability to enhance our offering. You know, we have finite resources. We're not a big government agency that the government can just throw money at. We get the money the government gives us, and we're not for profit. We don't have other income sources. And every upgrade we would do would actually enhance the well-being of our residents and increase our capacity. Then it gets to the rights again. We've got to make sure that in giving rights to the residents, we don't do it in such a way that it creates issues for my staff and the people that are trying to care for them. We have, under the Work Health and Safety Act, everyone's got rights, but they've also got responsibilities of their own. That means within their capacity. So that's the key part, is it must be within the cognitive capacity of the residents if you're making their responsibilities. No question about that. An example is recently an abusive family member came in, was abusive to me, aggressive to the staff as well, and it was a real battle. I had to get legal advice under the current Act to try and make sure that I was dealing with it in a way that didn't breach the Aged Care Act while trying to make sure we protected our staff. So.
Thank you, Mr Johnson, and to you both for your opening statements. I'm going to kick off with a few questions which I will put to both of you, given we're both here in person. We can see how we go with that. But you both mentioned challenges regarding the implementation timeframe. So can I just understand a bit more specifically what your concerns are and what you'd like to see?
Right, since you're looking at me as Chair, yes. I'll happily do it. First, our issue is timeframes. It's not that I'm willing to change or anything like that. I'll give you an example. We're currently implementing a software database to help us be compliant. That got delayed because we hadn't had an influenza outbreak in the facility, and I had to redirect my staff that were working on that project to go back to direct care. We only have so many people, and so that's the issue for me. It's timelines, and the issue I mentioned about the RN coverage. When you rush an introduction of something, when the government themselves admitted there wasn't enough RNs, if you rush it, you get what you rush. You don't get the benefit because resources go the wrong places.
And Ms Meredith, in terms of the 1 July 2025 commencement date, are there specific barriers that you've identified?
I think what we're challenged with is really outdated IT systems as well. So we are already on a path of upgrading our IT infrastructure. It's costly and it's stalled at the point of pricing. We need to make sure that we budget for it. Sustainability is always an issue in the region. You do have expenditure that the city counterparts don't necessarily incur, so we've always got sustainability front of mind, as well as provision of quality care. I think the timeframes for us that would assist would be 6 to 12 months as well, knowing that we're already embarking on this IT implementation and knowing the impact on our staffing and our resources. Being a single facility, we don't necessarily have a huge big corporate back office to support us, so any change needs to be carefully considered. Change management, procedures, policies, procedures, proper training, all of those things really need to be considered in a small organisation. Most of our staff are on ground delivering care. So when you're taking them away to implement change, you do need to have that backup as well. So limited resources from a corporate perspective. If there were the opportunity to combine and assist with the development of procedures and assist with some of that background training modules for staff, I think that would really make sense. Everybody's duplicating effort by engaging consultants, and it then is a lot more costly to be able to implement things within one organisation. So if we were able to get resources that were consistent across the field, we'd then have a consistent approach to policy, a consistent approach to procedures, training, etc., and it would help us out as a resource and enable our sustainability.
Thank you. Can I ask for both of your perspectives on the importance of moving to a more sustainable model of funding for aged care?
Do you want to go?
Okay.
I think sustainability, as I said, is always front of mind. At the moment, we are cake stalling. We are raising funds. We are approaching community organisations for assistance. We are really trying to promote the urgency of investing in aged care in our region. We can't keep that cake stall approach to raising funds in aged care. We don't have the resources, and the community are tired of putting their hand in their pocket. Even providing land or the assistance that was provided back in the early days by the communities, I think it's unfair at this point to ask them for assistance for organisations to become sustainable. Our boards are volunteer boards. All the money that we make is reinvested back into our organisation, and still at that point it's not enough to reinvest in adequate facilities. We have been awarded a grant of $12.85 million in the capital program that's just been run in thin markets. So now we're going to be embarking on another major 30-bed extension. That's going to put quite a bit of pressure on us as an organisation as well, because we are going to be co-contributing. Worrying about the build and being able to reinvest, and then also worrying about sustainability is something that we need support with straight away. If we need to increase quality of care, we need to increase our care minutes, upskill our workforce, and also invest in our own infrastructure. I think it's a risk to regional organisations, regional care providers.
Thank you. Mr Johnson?
And ours is along the same lines. We're not for profit. We have to go to people for some other support, etc. The issue is that the uncertainty of funding, but also the government brings out new things it wants done, and you're supposed to then resource that from what you've already got, but the funding you're getting is barely enough to actually keep the doors open, to keep us operating on a day-to-day basis. So when the government is thinking about new initiatives, they should be providing some one-off funding to fund how we adapt. Maybe that would be incentive then for the government to come up with systems themselves. Even training packages, where they provide the training package which the Commission will find compliant, rather than us having to work with people to develop those or pay people to develop those. So there's no one-size-fits-all with regards to funding. Like with us, our profile of our residents changes dramatically. But also in aged care, the reality is the profile is going to change, because with the increase in home care, less people are going to come in when they're younger and fitter into aged care. The reality is our clients are going to be either more infirmed or closer to end of life than they have been in the past. Last year we had a resident pass that was with us for 31 years. That'll never happen again. The reality also is that our respites are, again, for very short periods of time. And is the funding for respites adequate, given you can't get accommodation costs out of a respite person, but they are still covering a bed? So there's a number of funding issues that need to come out in the future. But yeah, we need more, but I can't tell the government exactly how much we want, because the model keeps changing.
Thank you. And can I ask about, we spoke a bit about workforce as it related to RNs and the availability of RNs, but how did you find the impact of the wage increase for aged care workers on recruitment and retention? Did it make a difference to your workforce?
It did. There were a few different impacts that were positive. So staff that were awarded the high wages felt valued. The publicity around it was really beneficial. The Royal Commission and the negative publicity around aged care really damaged people's incentive to work in aged care. The damage was, the reputation of aged care was damaged. We aren't all in the same category of, delivering poor service. Some of us have got really good reputations and we really pride ourselves on it. But we were absolutely impacted by COVID on top of the impacts of the Royal Commission. It did incentivise people to work in aged care, and it gave us, something tangible for people. It put value on women in the workforce as well, because our workforce is predominantly women. We were really glad that we were funded for that as well. We wouldn't have been able to fund that amount of award increase without impacting on sustainability as well. So the increase for us or where we don't meet our workforce obligations and our pressure points are with our agency staff that we have got on board. Even though there were wage increases in aged care, and there were certainly grants applied to aged care workers to keep them in aged care, those grants also applied to agency staff that were working in regional locations. So our agency staffing is huge, and our cost is about $1.3 million per annum to actually have agency staff. We've got 7 agency RNs versus 5 full-time RNs in the organisation. We have to provide accommodation, flights for them as well. So even though the award wages have been welcomed and those changes have been welcomed, other pressure points have really impacted on the value of the registered nurses in aged care with the competing agency staff, and we're still trying. We're battling against state government, Department of Country Health SA, hospital systems. We are competing for the same workforce.
Thank you, Ms Meredith. Mr Johnson, did you have
I'm
a
not going to
perspective?
repeat everything that Nikki just said, but about everything that Nikki said applies to us as well. The key part with the funding of it, though, the government funded 15% of a 21.6% increase, and the government funded 50% of the historical leave balance impact of that 15%, not the 21.6%, but the 15%. And yet the government has not provided the other 50% at any time that I'm aware of. So the funding was helpful, but the government was the one that said, hey, let's increase the wages, but they only funded a part of what the increase was. That's my concern there. With regards to agency, yeah, $1.427 million in the submission last year for agency staff. It's about, as I said, about $888,000 last year alone net, if we had to have some of those people as our own. It's the accommodation costs, it's the travel, you've got to pay for everything for them to come over, plus a premium wage, plus people already in the industry are resigning and joining an agency because they get a higher rate of pay. So, which creates the perfect storm. You know, you've got a mandated thing, we can't meet them, we're under threat of sanctions by the Commission. They use lovely words like best endeavours but don't define it. So it's not sustainable the way things are going at the moment. We are competing against, I'm competing against Matthew Flinders, they're competing against us, and we're competing against home care, and we're competing against the hospital system, right? And we don't have the financial resources the government's got to keep propping things up.
Do you think the wage increase was welcomed by your workforce?
Definitely welcome. No question about that. In fact, what we did, we gave it to everyone, not just the direct care. And that was a board decision, because our board believes that they all contribute an important part to the delivery of care. Just because they're behind the scenes and not seen as much by the residents does not devalue what their input is. And I know there's complexities that care workers have, and that's been talked about in the wage decision. But the reality is there's complexities. The same infection control processes have to be dealt with by everyone who works in an aged care facility, not just the ones that are face-to-face with the residents.
Thank you, Mr Johnson. Senator Ruston.
Thank you very much. So can you just quickly, do you do home care and CHSP as well, or just resi care?
Just res care, home care and res care.
Okay, right. Fantastic. So I'm just wondering, first of all, from a RAC perspective, do you have any idea what the bed shortage would be in Port Lincoln at the moment for people? Do you have waiting lists?
What was that? I didn't.
Do you have waiting lists, the bed shortage? Do you have waiting lists in Port Lincoln?
We currently do. Our bed shortage, I checked this morning, was about, we have 60 on our waiting list, which doesn't necessarily, 60. Yes. That's people anticipating that they'll need care in the next 6 months. We get phone calls daily from the hospital asking to place somebody. We get phone calls from family members absolutely distraught because there's nowhere to put their loved one. They're, on home care packages, they're looking after them in home until they reach a critical point, and the hospital system's unable to sustain them once they're admitted to hospital, so they can't go back home. They get sent to Ceduna, Elliston, Streaky Bay, Adelaide in some cases as well. So it's a dire situation, and it's absolutely urgent that we address the need in Port Lincoln from a bed shortage perspective.
That's your experience as well?
Very similar. I can't remember the actual waiting list at the moment, but we do have people on a waiting list all the time, and we're always getting the phone calls from the hospital, can you take so-and-so, and from family members, even the simple ones where they want to put them in for respite care because they need to go away and have a breather as a family. We're not always able to support that request as well. So there's definitely a shortage of beds in Port Lincoln.
Do you have any idea of the quantum of the number of people who have ended up in hospital and subsequently are unable to go back home again, who have actually been moved out of town? I mean, it sounds to me like the most...
Senator, I think that's a better question to ask to Port Lincoln Hospital.
Okay.
Because we would only know the ones they phone us and we can't accommodate, and we don't keep those records. So I would suggest that...
Does that happen very often?
Yes.
Yes.
Okay.
Yes.
Yes.
Okay. Can I just then take you to your agency staff? You made a comment that you think that you've seen some of the staff making the decision that they'll work agency because they're going to get paid more via agency. If you then, add to the cost of that, obviously the agency overheads, so that you're being charged is a whole heap different to what your staff members being paid. Clearly, so do you think there is a new industry being created around agency?
Senator, I've addressed that in my submission to some degree.
Sorry, I only got it this morning.
No, that's fine. I'm just saying there's more information there from what I'm about to say. The reality is that, yes, we have staff that have gone off, and I've actually said to my Director of Care, we are not recruiting and not using any agency personnel that have previously been on our books as employees that have resigned to go and join an agency. Because you can't, if you don't stop that, it'll be just a self-fulfilling, someone else will do it, and suddenly it'll go back to all agency staff.
So do you think there is a model of care that could be applied in markets where these challenges exist? Because, at the end of the day, nobody wants a substandard care offering to anybody, no matter where they live.
Yep.
But, markets do have, flexibility in the marketplace is something that we should always be looking towards. So, is anybody asking the older Australians in your community, the ones who are being shunted off to Elliston or Ceduna when their families are here in Port Lincoln, about what they want and whether there would be a model of care that would be able to be appropriately applied that wasn't so heavily mandated? I'm
not aware of that. I don't know what Nikki's answer there is, but our aim is to try and provide as many beds as we can. But because of the RM mandate, we reduced our beds, and we're still climbing back up.
You're not back at full capacity?
No, because we're trying to reduce our reliance on agency nurses because we can't afford them. You can't afford it ongoing. $800,000 a year over what your normal in-house cost would be. You just can't keep doing that.
Would enrolled nurses being able to play a greater role in the care minutes make a big difference to you?
Enrolled nurses that are experienced, I draw the comparison. The legislation recognises the care minutes provided by an RN, new graduate, day one out of university. No practical experience whatsoever, but doesn't count a 20-year veteran EN's care. I've suggested this in letters which are attached to the submission to the government. They should be thinking about realising that enrolled nurses have a valuable role to play in delivering care and aged care. They have done for decades. We, as a facility, and I'm pretty sure up the road did the same, we had enrolled nurses quite a bit and an RN on-call roster for when needed, and we're only literally, if they're even closer than us, we're only minutes away from the hospital here. The model of care needs to be a better blend, and we talk about inflexibility of mandated, and again, it's in my submission, and I know Nikki feels the same way. Having inflexible care stops our ability to be innovative in how do we deliver the care needed by residents and wanted by residents, because we have to use RNs. So,
If I could talk to the model of care that we've set up at Matthew Flinders Home, we certainly have our existing staff, but in 2023 we completed the building of a rural health and aged care education centre in collaboration with UniSA, and that is a dedicated training centre for registered nursing and allied health students. So we have the facilitators based in Port Lincoln providing direct facilitation and support to the students that are doing an aged care placement in our home. It's been really, really valuable for us to have that as a collaboration with the university. We've seen a really good uplift in quality of care. The nursing students under supervision of the registered nurses and also the allied health students under supervision of a qualified physio, speech pathologist and OT have led some really good programs that are dedicated to quality of care. They've assessed the speech pathologists have been able to undertake swallowing assessments and made recommendations on the equipment that we use. They make dietary recommendations. The speech pathology students under the supervision will run falls and balance clinics. So, all of these wraparounds are absolutely having a positive impact on the quality of care that we deliver, but none of this is recognised under the existing model that is mandated as well. None of it can be counted. It's very concerning for us because we're seeing reduced falls risk, reduced falls. We're seeing so many improvements to their daily life, but it's not captured. It's not captured in the legislation with the mandated care minutes as well. I think I would recommend or encourage that it was broadened and reconsidered. The disciplines are learning from each other as well. They may not necessarily all end up working in our facility, but it certainly is improving and giving them an exposure to aged care, which is then enticing them to work in aged care in their futures as well. So the model that we've got set up is innovative. It was funded by the Commonwealth Government, and it's it was the Department of Rural Health Expansion Program. So it was a capital grant. So we received the grant, University SA received the grant, and then we received the money to build the facility, which had to be co-located on an aged care facility.
Were you the only one in Australia that got this grant, or were
there
others?
were 7 grants around Australia and demonstration sites. We're the only ones as an individual single facility as well. Most of them were with multi-purpose services.
So what involvement have you had subsequent to running the program, feeding the information back into the department? Because it seems like an eminently sensible thing that you're doing. You've got the results that
Yes.
are coming in.
Yes.
Are you seeing any sort of, what's the process of feeding the information back into the department? Because clearly this bill is not very reflective, and some of the previous legislation is not reflecting these innovative approaches to care.
Yeah.
So why, my question is going to be, why on earth would you fund something if you're then not going to listen to what the outcomes are?
Yeah, well, I question the same. All of the targets and KPIs around that provision of the grant are being met, and that was relating to student placements. So we're conducting our own assessments as to improvement of quality of care, and trying to evidence the improvement in quality of care.
So have you published, what is the feedback mechanism here for the demonstration of your outcomes of your research?
UniSA are part of the group.
Yep.
That will then, I presume, provide feedback. So they were the recipients of that grant. We would love to shout out about it and really showcase that it's a really good quality of care. It's really, really impactful, and it's an innovative model that can be adapted as well, adopted and adapted.
Okay, so to the department who's listening, we would really like the outcomes of that University of South Australia program. Thank you. So don't be surprised when I ask for it in estimates. I'm sure they're listening. Can I just go to my favourite questions? In both of your residential facilities, what's your breakdown of RAC and RAC combo? I sound like I'm talking in acronyms, don't I?
Because I heard that question earlier on, Senator, I've had one of my staff look at our ratios. And we have 6 people on DAP, which is, for those who don't know, that's where they've come into the facility as a supported person and then become non-supported due to change in circumstances. So we have 6 DAP, 7 DAP partial RADs.
So DAP or DAC?
DAP. And then we've got 19 RADs, 12 fully supported, 8 DACs, and 1 RAC. So it's a diverse mixture of them. So, but about 43% of our residents are what they call supported residents.
Okay, no problem. And you, Ms Meredith?
We have 14.47% full RADs.
Yep.
We have a 9.21% combination of RADs and DAPs. We have 35.53% of combination DAP and DAC. And then we have a balance of 40.79 fully supported residents.
Okay.
So supported residents would include a component of the 35% plus the 40%. Yeah.
Okay, yep.
Senator, I've got a answer to one of the earlier questions that you asked about the hospitals. At least 2/3 of older persons in hospital go regional due to local bed shortages. So they go away from Port Lincoln.
2/3.
And 90% of our recent admissions were returning older people back to Port Adelaide to be with their families.
Shoot.
So so they've come back from elsewhere on the peninsula or even in Adelaide to be with their families.
Wow, okay. That's quite terrifying. So the other question is, do you have a cost per room? And I say it, I suppose, because I'm trying to get an understanding of, in order for either of you to be able to be in a position where you would be financially bankable to the extent that you could build in your own right, is that like just a pipe dream, or is that possible?
We're at the very early stages of that process, so we haven't done the figures on what it costs per bed in reality anymore at the moment. We've got some basic figures which were mentioned in the last presentation about it, but we're so busy dealing with the current changes and having limited resources internally in the administration area. It's not work we have to do at the moment, because what we're trying to do is make our systems match what we need to do to deliver what's mandated. Our ability to be innovative and some of that stuff is limited because of that. So.
Yeah. You in a similar...
Yeah, I don't have too much to add to that. We haven't got a breakdown of the cost per room. I know that we do have a diverse range of rooms, from shared rooms to new single rooms with ensuites. We embarked on a refurbishment of a whole lot of our rooms in 2022. We completed it. So we have got the new single ensuites, but then we also have the dormitory style rooms with shared bathroom facilities as well. So to get a true cost per room, what we have done is just average our costs out over all of the rooms.
So what's your maximum RAD?
I don't want to quote it. I will take that on notice. Our maximum RAD is under $500,000 though.
Okay, what about yours, Mr. Johnson?
All of ours are 300,000. We're at the process of trying to go to the independent regulator on pricing on that. But every room, so all of our rooms are single person accommodation with their own individual ensuite. So.
But I mean, if you look at 300,000, I mean, in this current market, you wouldn't have a hope in hell of being able to build for that.
No. And I think the reality is, I think yours was just over 400 that I saw. In the paper I did my own board. So our boarders have approved me to start looking at an increase, because our prices haven't changed since 2015, I think. So.
Because I mean, if you're looking at $300,000 with your RADs, even with the retention component that's being proposed, it's going to not have quite the same impact as it would have.
Regional areas just don't get. It was mentioned before. Regional areas don't get the RADs.
Yeah. So to that end, I mean, one of the great challenges, obviously, in shallow markets is because you aren't commercially bankable for the reasons that you've outlined here, and I don't imagine that's going to change anytime soon. Is there any thing that you'd like to put forward as a means by which you could get greater certainty around funding? And it could be both around, your operational funding, so your ANAC, in terms of your shallowness of your market with your nursing staff, or from a capital perspective around the ACAP program. I suppose, is there some mechanism that you would like to see improved so that you can't constantly go and cap in hand back to government if you need something? Because, we clearly have got a great demand in the community for more beds, but the only way that you are going to be able to build more beds is if you, first of all, solve your staffing crisis, and secondly, that somebody provides you with a grant to enable you to build. And as we heard from an earlier witness, $12 million for 17 beds, we're talking about some pretty significant investments here. Do you have a view about ways that could be improved so that you could actually meet the demand in your community?
I certainly do feel that could be an improved process. Our board's embarked on a master planning process. The master planning process is like a lottery, really. Are you going to get the capital funding to progress your master plan to meet the needs of the community and to bring our beds up to a proper standard to meet the new aged care design guidelines, principles and guidelines? Having that master plan from a funding perspective would be really, really valuable, because we could get efficiencies in rolling our building processes through and having continuity of funding. So, if we're saying we're going to be building between now and, in 5-10 years' time, it would be really beneficial to have that matched funding from the Commonwealth, some sort of commitment as well that would support that. Our infrastructure is terrible. We've invested our savings in rebuilding our facility and refurbishment, so we don't have the opportunity now to say, well, we can save up any more for it. This is going to be a problem that we will encounter from now on. So we really do need to progress the grants programs. Yep.
We do need to rotate now, so I'll go to Senator Pratt and then Senator Kovacic. Before we do, can I just ask those joining us by teleconference, if you're not speaking, to please be on mute, because otherwise we get quite a bit of feedback for those online. But Senator Pratt.
Thank you very much, Chair. I seem to have a bit of reverberation on the line as well, and I hope it's not coming from me. I wanted to ask, we've touched on this already with respect to capital raising. I'm interested to hear from the context of you as regional providers, the opportunities in the new bill and the challenges. For example, I note that some residents might move from other regions in the state where there might be different levels of equity that in family assets that people may access, but also, how you think you'll manage those issues going into the future.
One of the comments that I got from some people that have heard about the proposed retention of the RADs is, hold it, so I'm not going to have my money. You're going to take my money off me when they talk about the $300,000 RAD. They're already concerned about having to pay $300,000, but potential losing 10% a year of that actually is of concern to some of our residents. So not everyone is a wealthy person where that's not going to concern them. So that's really, that's one of the challenges out of it. It's an opportunity for us to get some money to do capital, but what does it actually say to our residents? And then we have to convince them that what they're getting value for money on that ourselves, rather than it just being part of it. There's lots of challenges in it. So.
There's no way that we can match city prices. You compare things like even the North Shore. This is an extreme example, I'm sure, but North Shore of Sydney, as opposed to a regional town, the housing market is what we usually base our room prices on, and there's no way that we could ever meet. Even though we've got beautiful brand new facilities, some of them are brand new facilities, there's no way that we could meet the same housing prices that are reached in the city, that are found in the cities. Yeah.
we do have a witness on teleconference whose phone's not on mute. If I could just remind those who phoned in to please pop their phone on mute. Senator Pratt, did you have another question?
No, I just wanted to observe the excellent evidence around the collaboration with universities. That was really good to hear, given my experience in Western Australia and the fact that we're opening similar university hubs, regional health university hubs here too. So thank you for that.
Thank you.
Thanks, Senator Pratt. Senator Kovacic.
Thank you. And it's a quick question from me, and the same one that I asked in the last session for each of you in terms of, the realm of all of the changes that we're seeing here, and, the broad acknowledgement of the sector that, change is necessary. What concerns you about it, and what effectively is keeping you up at night in terms of, an unintended consequence or something that you wouldn't want to see occur as a result of these changes, particularly for remote and regional communities?
I think unintended consequences would be the impact on sustainability of regional providers. I can say that one day of training in our organisation would equate to, say, $50,000 to train all of our staff for one day. And if organisations have got a budgeted profit of $200,000, it's impacting massively on their sustainability. So having right timeframes, but also having the really good support around implementation would be, and also financial support, but also support around the resources, to me, would make a big impact. That really worries me, is our own ability to implement all of the changes without the support that we need.
I agree.
So effectively having...
Sorry, Senator, I cut you off.
Apologies, I just wanted to confirm just a mechanism around providing support or training resources for your staff or your teams, so that you're actually not, as you say, using a fifth of your annual profit effectively to retrain people. Is that what you're talking about?
I am. That was an example of potentially one-day cost. Yes. So certainly the ability to have resources provided to us, so we're not all duplicating effort and not all recreating the same policies, the same procedures and the same training materials.
Understand. Thank you so much, Ta.
Yeah, from our point of view, it's the same as Nikki regarding the training and the resources and what have you. I won't go through the extra words that she used. One of the things that has scared my people is the thought that the talked about criminal penalties could be reintroduced in the Senate. Can I just say clearly, as I put in the submission, we will lose staff immediately, and I'd be one of those people if the government decided to impose criminal penalties for aged care workers. We're having enough trouble recruiting people into aged care right now without criminal penalties. If you introduce those, then what you're going to have is only those people that can't work elsewhere are likely to be taking the risk against criminal penalties, because I can get work in other places. I really enjoy my job. I really enjoy the industry, and I get a lot of enjoyment out of it, and a lot of my team do too. But in the end, why would I run the risk of criminal penalties from some arbitrary decision of a third party if I don't need to do that?
1 minute left, Senator Ruston.
I just wondered whether you had any view about the requirement for the provision of supporters. There's no representatives anymore, but it's still supporters in the Act, and the potential for complication, confusion and the interface with the existing state and territory power of attorney and the other.
I think it's very confusing, Senator, and I think that needs to be clarified. At the moment, I'm really concerned about how we're supposed to transition from one to the other. When you think that I've got more than half my residents of some sort of cognitive impairment, and their ability to change from their current process to another is going to be very difficult. So what's the transition provisions? If you're no longer recognising the power of attorney for those people, how do we go? So I don't know the transition provisions that are in there and what's not there. So I think that's an area of the Act that maybe deserves a lot more time, a lot more consideration, and comes back at some later stage as an amendment to the bill. So may I suggest that the government seriously consider removing provisions about supporters at this point in time, have proper consultation with the industry and even some of the residents about how they feel about that section. Because I asked, has the government actually consulted with residents over that provision in the bill?
Yeah, thanks.
Okay, thank you, Mr. Johnson and Ms. Meredith.
Sorry, I just wanted
No, I would second that as well. I think it's complicated enough at the moment.
Well, thank you both for providing evidence to our committee today. Again, I don't believe you took questions on notice, but if you did, we're asking for those to be returned by close of business on the 21st of October. But you're free to depart now, and thank you again for your participation in our processes.
Thank you for the opportunity.
We'll now be welcoming a panel of lived experience witnesses to our session, and I'll just give those individuals a moment to join us at the table. I'll just confirm we have Peter on teleconference. I believe so. Okay. I'd like to thank you all for appearing before our committee today. This section is an opportunity for you to make a short statement to us. It's primarily a listening exercise for us as senators, so we won't be expecting you to answer questions of senators, but it's more of an opportunity for you to share your experiences and your story with us. I'd like to remind you not to disclose any personal or private information, such as your date of birth or your home address during this statement. That's because we're broadcasting live and that's available publicly, so just please be mindful of the information you're sharing. There's not an opportunity to go back and take it off the public record once it's been said into broadcasting. To assist in keeping time for this session, the Secretariat will have an alarm which will go off when it's time for you to start wrapping up your thoughts. So it won't be a hard cut-off, but when you hear that buzzer, that's a good indication you will have had about 7 minutes, and it might be time to start closing your thoughts to us, just to help us keep on time for the day. Do you have any questions before we go? Happy to go? Great, excellent. I'd like to ask each of you now, please, to state your first names only for the benefit of the Hansard transcript, and we'll start with you, Jennifer.
My name's Jennifer.
Thank you.
My name's Hannah.
Thank you. And do we have Peter online?
Yes, my name's Peter.
Thank you very much. Peter, for you, if you're as you're by teleconference, just a reminder to speak clearly into the telephone and just identify yourself as you speak to assist with the recording and broadcasting of these proceedings. But we'll now move to these statements. Again, you'll hear an alarm when it's time to wrap up, but we might just go in this order. So Jennifer, if you'd like to go first, or unless Hannah wishes to.
If it's not a problem, Hannah would like to speak first. She has a medical issue.
I have oromandibular dystonia, which causes my muscles of my face to go into spasm. And the further the day goes on, the harder it is for me to speak. So if you don't mind, I'd like to speak first.
Not a problem. Thank you, Hannah. Please proceed.
Thank you. Thank you for the opportunity to speak and hopefully be heard today. My husband and I have travelled 800 kilometres from south of Adelaide to be here today. It's a long and expensive exercise. But I believe so strongly in this new aged care bill that it's going to be so detrimental to the elderly citizens of Australia that I was determined to come here in person today. I wanted to be able to see you face to face and stand here before you bereft. Bereft because I fear for our future as we progress into old age. Under the current Act, although not perfect, it gave us a sense of security, knowing that we could have the necessary services to enable us to continue living in our own homes. First and foremost, the Aged Care Act was designed to give the elderly more rights and the ability to stay in their own homes rather than going into a nursing home. Under the new Act, this will be impossible. Our rights will be eroded. The new bill appears to give providers more rights than the consumer. They even have the right to step in and petition the Guardianship Board to be allowed to take over the full care and financial management of a person over and above family members. They do this when they don't like complaints from family, complaints about mistreatment, and providers then have the power to ban family from visiting, and that has happened. We need consumer choice and control. I asked members of the forums I belong to let me know what their main concern about the new bill was, and overwhelmingly their responses were 1 hour of cleaning per week is totally insufficient. It may actually be 2 hours per fortnight because the government has mandated that we must employ support workers in 2-hour blocks. 18 hours per year of gardening is totally inadequate. There were over 100 responses to my question. Other major concern was co-payments. We'll be living in squalor. Our houses will progressively become dirtier. Our gardens are more and more unmanageable. And for those who live in rural areas, we're going to have snakes in the garden, and it's just going to be totally unsafe. The elderly will become more isolated too, because who's going to invite people into their homes when they're dirty? There should not be any cap on any service. Everyone is an individual and has different needs. Minister Wells said in reply to a comment on her Facebook page, and I quote, "The thought behind proposing a cap on cleaning and gardening was to ensure that supported home recipients have enough funding in their budget for clinical care and other supports for independence, including social supports, personal care and meal preparation. But most of us don't need clinical support. We can shower ourselves, most can prepare meals, and many can still manage their washing. What we can't do is gardening and heavy cleaning. Therefore, we need gardening and cleaning support. We need our windows cleaned. We need spring cleaning." I self-manage 3 packages, my package, my husband's, and that of a friend of mine whose wife has dementia. Every month our provider, Trilogy Care, sends out a statement so I know exactly what funds we've got. They have a portal that I can look at and I can see funds in real time and I can see invoices. Every recipient of a home care package has to work with a care partner. I work with 3. Their role is to ensure that we have an adequate budget and that we can manage the services we need within that budget. For every item we need, there have been some changes that have come through in the last 12 months. For every item we need, we are forced to get a clinical justification from an occupational therapist. Need a $30 shower chair? Get a $600 OT report. Need a $20 walking stick or a pickup stick? A tipping kettle for $60? Get a $600 OT report. We need autonomy and funding to be able to go out and buy those items without interference from a provider or government. OT reports are bleeding our funds dry. If a provider doesn't deal directly with a supplier, such as Bunnings, we need to find the money ourselves up front to purchase the items, and this often means that recipients cannot have the items. In the past, we've been able to save funds in our package in order to buy high-priced items. This is going to change under the new Act. Instead, there'll be a loan system, so we won't be able to have new equipment. Instead, we'll be forced to have old equipment that's already been used by somebody else, possibly urinated and defecated on by the previous user. Items may not be fit for purpose. We're all different heights and weights. The allowance of only being able to carry over $1,000 per quarter is insufficient. What if there's a crisis and extra funds are needed in a hurry? Things take time. Co-payments. This is a big one. How are the elderly supposed to fund co-payments of 17.5% for cleaning and gardening out of their age pensions, which are already below the poverty line? We will be expected to contribute 5% towards the cost of a shower. We are now being charged approximately $65 for cleaning and gardening. Some people pay more. This is due to what's happened in the NDIS, so aged care prices have escalated as well. Some services are charged at $120 or more per hour. So for 2 hours, that would be $22.74 out of a pension. What pensioner can afford this when we can barely afford to put food on the table? Have you heard there's a cost of living crisis? By the time we pay for electricity, water, council rates, insurance, there's nothing left. We've been told if we're in the system already, we'll be grandfathered. But if we go up a level, as often happens as people age, we will lose that grandfathering. Not true? Well, that's what we had read. So I'm glad to hear that's not true. Thank you. So now I attended a workshop facilitated by Caregiver of OPAN, numerous webinars, read many documents. Not once was there any indication that pensioners would have to pay. We were told the wealthy would have to pay. Are we now considered wealthy? What about carers? Carers will bear the brunt of this. People, especially caring for those with dementia, will be run off. They're already run off their feet. How will they cope with extra washing, gardening, all those sorts of things? Lots of changes have already been implemented, so we're already being penalised. We're not allowed to claim for essential supplements, even when recommended by a doctor. Things like remedial massage are already off the table. Lymphatic drainage, which is a big problem for some people, causes them falls and pain, is no longer allowed unless it's done by a physiotherapist or a masseuse, and in country areas that's not possible, so it's not allowable anymore. We're told that everything we require in the way of service and items must be age-related, including physio. I ran that past my physio last week and he actually burst out laughing and wants to know when exactly does old age kick in. We're not allowed to truly self-manage. We're infantilised and treated as though we all have dementia. It's demeaning and frustrating. We need to truly be able to self-manage our packages. It would be good in country areas if family members could be employed, because it's very difficult to get support workers. Many of them won't even sign up to aged care because the onboarding is so difficult. We virtually need permission to live a reasonable existence. And these changes are going to lead to more pressure on hospital as more people become depressed and have health problems because they're trying to do the jobs that support workers should do. Suicide has already been mentioned on a number of forums that I belong to. It's frightening and sad that people are losing the will to live because they're so stressed that they may end up in a nursing home. With these changes, if we can't have gardening and cleaning and those sorts of supports at home, we will end up in a nursing home instead.
Excuse me to interrupt, just a note that that's the timer, so...
Oh, thank you. In summary, these are the points I would ask you to take away from this hearing. The new Act is ageist and discriminatory. Recipients need autonomy in managing their own packages. They need funds available for purchases that need to be paid for upfront. They should be able to have as many hours of cleaning and gardening and other support as they need in order to stay in their own homes. Pensioners cannot afford and should not be expected to pay towards services that will help them stay in their own homes. After all, isn't this what healthcare packages were designed for? The alternative is a tsunami of elderly needing nursing home beds, something none of us want. I implore the Senate, I beg you, not to let this bill pass into legislation as it stands. At the very least, please ensure that there are amendments in place that will enable the elderly to have as much cleaning, gardening and social support and maintenance as they need, and that we are not forced to contribute from our already insufficient pensions. Thank you for hearing my submission today.
Thank you very much, Hannah. Jennifer, please proceed.
My name is Jetty. My husband has a level 3 package assigned to him due to prostate cancer that has metastasised to his lymph nodes and bones. He has had 3 weekly chemo for 2.5 years, now pushed out to 4 weekly. He's had 4 falls, 2 of which resulted in broken or cracked ribs. Following chemo, he has to have an injection. I am his support person. Lived experience. How will the changes affect us? The co-payment is a huge issue. We are on a pension, and with the cost of living at the moment, people are already struggling to make ends meet. And I will say that I'm not just speaking for us, that I have done the same as Hannah did and asked questions in the forums that I'm in, and this is the biggest issue. The pension may have been increased recently, but the costs of everyday living have increased also. Car registration, insurance, electricity bills, not to mention food costs. Social interaction is affected. Travel is curtailed because of fuel costs. Some have resorted to only having one meal a day just to get by already, without taking the new co-payment into account. Next is the cap on domestic assistance. Lack of further domestic help and gardening hours will result in more clinical care, not less. This will have a flow-on effect to doctors and hospital visits in a system that is already stretched. Falls will increase, skin tears deteriorating into chronic ulcers, cardiac conditions, asthma and breathing difficulties, lung complaints, all due to exertion and stress and trying to cope. How is cleaning, laundry and other domestic assistance going to happen in 2 hours a fortnight? I doubt if anybody here spends only that amount of time cleaning. What will happen about simple things like doing the dishes? Are recipients supposed to stockpile dishes for 2 weeks? What about making beds? Are recipients going to sleep in unmade, sometimes dirty or wet beds? Showering? I foresee recipients foregoing showering because of the co-payment, and that will mean less healthy recipients. One of the things that comes up often is how people cope, the word coping. Stress is something that happens not just to the package recipient but to their carers. More work will fall on their shoulders with these new caps on domestic assistance. Other things that came up. There is a need to be able to carry over more than $1,000 per quarter as recipients save money to be able to purchase large-scale items like suitable beds. Excuse me. This should not be a one-size-fits-all approach. Every one of the recipients has different requirements for care. For example, short-term versus long-term needs. At home after surgery, there are definitely more clinical needs. Otherwise, most of us recipients have very simple needs to enable us to stay at home. Domestic assistance is one of those priorities. Providers need to make decisions on our needs more quickly. A doctor's letter should be enough, rather than an expensive OT report, as Hannah brought up. Sometimes recipients are quite ill and need help quickly. I personally know of someone who died waiting for reassessment or decisions by providers. Do those of us who self-manage really need a provider? We're not trying to overspend our budgets. Most of us have had lots of experience using money wisely for our needs or for those we're caring for. Providers want our workers onboarded, and sometimes just for a one-off gardening arrangement. And they sometimes charge our workers for the privilege. I'm not sure if you're aware of that. This is how they get around the cap on charging us. They get around it by charging travel time, by charging for people to onboard with them. The threshold for technology is nowhere near enough at $500. The providers for self-managed want us to use email, internet and the like, rather than telephone and face-to-face. Internet doctors or telehealth are often more readily available for those at home, and technology needs to be available to cope with that. How is it that a person who gives domestic assistance has any skills to report on our health? This is an invasion of our privacy. The promise was that we would not be worse off. As you can tell, that promise is already broken. Just the co-payment already makes us worse off, as most current providers don't charge any co-payment. In closing, I will read to you the Charter of Aged Care Rights. I have the right to 1. Safe and high quality care and services. 2. Be treated with dignity and respect. 3. Have my identity, culture and diversity valued and supported. 4. Live without abuse and neglect, and some of these areas, I believe, are neglect. 5. Be informed about my care and services in a way I understand. 6. Access all information about myself, including information about my rights, care and services. 7. Now this one is really, really important. Have control over and make choices about my care and personal and social life, including where the choices may involve personal risk. Number 8 is like it. Have control over and make decisions about the personal aspects of my daily life, financial affairs and possessions. 9, my independence. 10, to be listened to and understood. 11, have a person of my choice, including an aged care advocate, support me or speak on my behalf. 12, complain free from reprisal and to have my complaints dealt with fairly and promptly. 13, personal privacy and to have my personal information protected. And 14, exercise my rights without adversely affecting the way I am treated. Thank you for listening.
Thank you very much, Jennifer. Peter, who's joining us via teleconference, please proceed, Peter.
Good morning, Senators. I'm Peter, and I thank you for this opportunity to speak. As I'm speaking by telephone and invisible, I'd like to introduce myself a little. I'm an older citizen with a disability and use a wheelchair. My disability was incurred at the age of 6. I'm Vice President of Post Polio Victoria, board member of Polio Australia, and advocate for others in a like situation. My disability event was an illustration of how quickly life can be radically changed. I was an athletic kid, a fast runner, and came down with the flu one day. I was put to bed, and when I woke up in the morning, I couldn't move my right leg. That night, 2 men in white coats burst into my room unannounced and carried me out screaming to an ambulance in the dark street. I found myself alone in the strange room and learned early what it's like to be totally powerless. Now, for me and many others, there's a risk of once again of being confined to a room and totally powerless. Many old Australians are fearful of being put in a nursing home and subjected to the aged care system, doubly so for people with a severe disability. This new bill and the consequences that go with it greatly increase that fear. It literally gives people sleepless nights. We've had to watch powerlessly from the sidelines as the system is revealed bit by bit. The maxim, nothing about us without us, has certainly not applied. The airwaves have been dominated by government and corporate provider lobbyists, and their voices haven't been heard and certainly sought. So we are indeed grateful this committee is prepared to hear evidence from us, although hearing time still seems to be dominated by commercial interests. The poet William Blake asks, does the eagle know what is in the pit, or wilt thou go ask the mole? In this case, large providers, increasingly gigantic foreign investment funds flying high above the aged care pit, can't tell you what it's like for an ordinary Australian to be caught up in it, whereas we individuals know it all too well, as previous speakers have pointed out. Proponents of the system have been characterising nursing home residents as a retirement lifestyle choice, but the reality is it's not a choice, and it's certainly not about lifestyle. It's a catastrophe. As the government itself admits, nobody wants to go in, preferring to live in their own homes. But for some, the time comes when they can no longer safely live at home. A person can go to bed fit as a fiddle and sharp as a tack, with plans for the next day and beyond, but wake up unable to move or speak, having suffered a stroke. It happened to my own father. We can all imagine how that would feel and how we'd like to be treated if it did. In many ways, the aged care now proposed does not meet that test. There's a massive imbalance of power, which brings with it, of course, moral hazard. The Aged Care Royal Commission was set up after the public outcry over what was happening to nursing home inmates. So in that context, I have some concerns. The first involves enforcement of rights. Part 3 of the bill, Aged Care Rights and Principles, Division 1, contains a statement of rights listing a number of individual rights. That is in itself a good thing, but there's a catch. Section 24.3 of the bill states, nothing in this division creates rights that are enforceable in a court or tribunal. So we're told, these are your rights, but you can't use them. I understand that this committee is fully aware of this position and condemns it, for which we are grateful. Note that the bill provides for a complaints commissioner, but the commissioner is not independent. The word independent doesn't occur anywhere in the bill, in fact. The Complaints Commissioner is appointed by the Minister and for a period not greater than 5 years. Whoever is appointed would have to please the Minister if they want to be reappointed. In any event, they have no powers to make enforceable orders if a breach be found. Given the massive imbalance of power and the frailty and vulnerability of nursing home inmates in particular, it's crucial that there be recourse outside the aged care loop to an independent judicial officer. The good news here is that the solution is very simple. Just delete 2 words, only 3 syllables in fact. Deleting the words nothing and the word in allows section 24(3) to read, this division creates rights or duties that are enforceable by proceedings in a court or tribunal. Job done. Similarly with criminal penalties for provider conduct that amounts to a serious failure by the provider to comply with the duty to an individual, when that conduct results in the death of an individual to whom the provider owes that duty. The original exposure draft provided the possibility of a prison sentence in that event, which is appropriate given that the circumstances amount to homicide, potentially manslaughter in fact. The revised bill, the committee, in the revised bill before the committee, removes that penalty. Some are calling the result the 007 clause, license to kill. Once again, because of the imbalance of power and the frailty and invulnerability of the individuals concerned, strong protection is imperative. Carceral penalties, jail time, serve 3 purposes. 1, punishment. 2, deterrence. Perhaps most important for society. Potential wrongdoers weigh the personal consequences and hopefully choose not to take the risk. 3, the message that government takes the offence seriously and values the lives of potential victims. Removing the prison option has exactly the opposite effect. There's no punishment, there's no deterrence, and the government sends the message that regards the lives of vulnerable potential victims as valueless. Fines in this context have no effect because they will be paid by the corporation who will merely write them off as part of the cost of doing business. To rub salt in the wound, the original fines have been halved. Hence, I respectfully submit that the option of a prison sentence must be restored in the bill. The argument against the prison option seems very weak. Lobbyists say that the risk of imprisonment would deter some from joining a nursing home board. But the criminal penalty relates to an individual. It's not vicarious. And that's precisely the point of a criminal penalty. We want to discourage people who entertain, even in the back of their mind, the possibility they might perpetrate conduct resulting in the death of an individual in their care. In any event, the threshold for conviction is very high, requiring proof that the misconduct was serious and that it actually caused the death of the victim. And my next submission relates to the RADs, which I've already presented in my written submission. I won't go long into that. But I submit that refundable accommodation deposits and daily accommodation payments should be removed from the bill. It's obviously unconscionable for providers to extract free investment capital from frail nursing home inmates under the provider's control. I understand this is peculiar to Australia. In other countries, commercial corporations are expected to raise their capital on the market in the usual way. In particular, daily accommodation payments, DAPs, are unconscionably harsh, imposing interest of 8.3% on a very large sum, $1 million in some cases. This interest payment, as I understand it, is not covered by the lifetime cap. Hence, it will render nursing home inmates destitute. Public discussion doesn't mention this, nor was it mentioned in second reading speeches. Speech after speech mentioned the lifetime cap as a relief, but it seems, from what I can understand, that's not the case. I think this is really important because these DAPs finally are more onerous than the actual living, hotelling costs and so on. I would be grateful if the committee investigated that aspect. Now, finally, recommendation 72 of the Aged Care Royal Commission recommended that people with a disability within the aged care system should receive the same support as is provided by the NDIS. That was supposed to be enforced by July the 1st this year. We're now 3 months overdue. The bill as it now stands makes no provision for disability support. The aged care support at home system is designed for age-related frailty, as we've heard from other speakers, and covers regular payments for services such as cleaning. There's nothing to cover disability, which involves occasional expenditure for a piece of equipment, such as a powered wheelchair or home modification for accessibility. It's what economists call lumpy expenditure. It doesn't happen often, but when it does, money is needed in a lump sum. It can't be just dosed out. So aged care system, even now, is not appropriate for disability support. It is now even worse under the provisions of the new bill. And I submit that the new bill, if it does nothing else, should forthwith implement Recommendation 72 of the Aged Care Royal Commission. Personally, finally, in conclusion, I believe the underlying problem is the bill and associated policy is driven by ageism, elevated to the status of an ideology. Boomer bashing is a constant theme, its promotion, making rich, greedy boomers pay, for example. There have been a stream of articles put forward by lobbyists along those lines. Other speakers before me have mentioned the ageist aspect of the bill, and I fully agree with them. So I submit the bill should be scrapped and a fresh start made on a rational basis, not tainted by ageism, with input from the grassroots. I think that what this committee is doing is very important work, and I am pleased that they are hearing from real people, as it were. I think it is crucial that it be fixed now because it's all going to finish up in tears very soon in its current form. But I think we should start afresh with emphasis on producing as good an aged care system as we can get, world's best practice, before going on and going into matters of funding and slugging people who are not rich for money they simply don't have. In fact, the irony is that the generally rich have millions at their disposal are very mildly affected by the new provision. But I recommend that the committee continue on this good work of gathering information, and I hope that there will be considerable change at least that rights and criminal penalties shall be enforceable. At least if we get that, there is a chance that our legal system will generally fix it to some extent. But better still would be to start again on a rational basis. Thanks for listening to me.
Thank you, Peter, for your evidence, and I'd like to thank all of our witnesses for this panel for sharing your experiences with us, and especially noting those who've travelled to be with us today. We really appreciate you being a part of our process here as a committee. The committee will now take a suspension for lunch and will be recommencing at 1 p.m. Thank you. Kick off. And I would now like to welcome, thank you very much, representatives from Retire Australia and Retirement Living Council. Thank you for appearing before our committee today. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, could I ask you each to please state your full names and the capacity in which you're appearing today?
Daniel Gannon, Executive Director of the Retirement Living Council.
Brett Robinson, CEO of Retire Australia, and I'm the Vice President of the Retirement Living Council.
Fantastic. And do either of you have opening statements?
Yes, thank you.
Okay, please proceed.
Thank you, Chair. Look, the Retirement Living Council is the national peak body for Australia's retirement living sector, representing for-profit and not-for-profit owners and operators of retirement villages and seniors living communities right around the country. We broadly welcome the Australian Government's aged care reforms through the Aged Care Bill and support the Government's aim to put the individual at the centre of the aged care system through a rights-based framework. Retirement villages already provide home-like environments and services that enable older Australians to age in place. We support reforms that give our residents more control, more independence and more support to stay in their home in a retirement village setting for longer. As an industry, we are excited and energised by the opportunities ahead for Australia's retirement living sector, and we feel enormous pride for the work that our members do in creating purpose-built, age-friendly accommodation that has been shown to enhance the health and well-being of the 250,000 people who call one of these communities home. Appearing with me today is Dr. Brett Robinson, Chief Executive Officer of Retire Australia. As Brett said, he's also a VP of the Retirement Living Council. Before handing over to Dr. Robinson, it's important to note that Retire Australia is an excellent example of the retirement living sector's evolution in direct response to the demands and expectations of the older Australians who choose to live in a privately funded retirement community. Many of our members are driven by a desire to improve the offering of wellbeing, care and support services within their villages to ensure a continuum of care that allows residents to remain living in the community for as long as possible, delaying or even avoiding altogether the need to move into residential aged care. Thank you.
Thank you. Dr. Robinson.
Yeah, thanks, Senator. So Brett Robinson, CEO, Retire Australia. I'm a clinician and have spent over 20 years in healthcare leadership roles and have only been new to sector in the last 4 or 5 years. I've been fascinated as to what I've discovered and was brought into the sector by the owners of Retire Australia to move the business from being one that was predominantly focused on property and accommodation to elevation of care and support for our residents. We're one of the largest operators in Australia, have over 5,500 residents, 650 staff, 29 villages across Australia, and have a development pipeline where we're delivering 2 new communities. We have 2 in development application modes and 2 that we are currently just acquired. A quarter of our retirement villages are in regional Australia, including here in Port Lincoln. Daniel and I have only just come from morning tea with our residents here in Lincoln Grove, where we have over 120 residents living independently with support. So Daniel's family actually built the village, and so he and I enjoyed telling stories of his time here 20 years ago when he was a young boy. And I guess it was a great example of, the purpose of our organisation being that we are here to provide thriving communities that allow people to live independently and live the lives that they choose to live in the principle of a home, but to end of life. Organisationally, RA's response to that has been to look at the built form and how we allow people to live independently, but also to provide services into their homes that allow them either to access home care support in their homes or in our newer communities where we are building high acuity services, effectively private aged care operating models. I have a personal story. My mother and father are from Toowoomba. Dad was declining significantly with Alzheimer's disease over the last 10 years or so, and in the last 5 years of his life, Mum was caring for him at home. Mum held on, we held on too long at home, and Dad passed away quite quickly after 6 weeks in an aged care facility. 2.5 years ago, Mum moved into one of our villages in Toowoomba in her mid-70s, and the impact on Mum's life has been enormous. She is happier than she's ever been, healthier than she's ever been. She's a social woman that's connected back into her community and family, and I only just showed Senator Ruston a photograph she just sent me today of her rosebush that she has cared for outside of her community. And I guess that is the role that we play in supporting the 250,000 Australians on average age of 82 that live in our sector and support them. I think the important consideration from our perspective around the aged care legislation is how does it intersect in what we do? How do we enable and support looking after older Australians? How do the home care packages and the changes in legislation enable that? And also, how do you support the accommodation of those residents? We're actually quite optimistic and positive about where you've landed. I think that this positioning about user pay, the pushing of more funding towards higher acuity in the older resident really aligns to where we see the opportunity. And I guess what we're asking for you to do is to really consider what we do and to ensure that what you are doing enables innovation for organisations like ourselves. Thank you.
Thank you, Dr. Robinson. I might kick off and just staying on your last point. One of the questions I had for you is how you thought support at home could enable the delivery of innovative ways of providing aged care in retirement villages. And can you give us some examples of that?
So what we're excited about is the shift you've made towards sort of more of those more domestic services where people have the capacity to pay that they do. So maintenance, gardening, cleaning, personal services, and are pushing more funding into high levels of acuity. I think your packages are going to tap out at about $75,000 to $80,000. I think that allows residents to receive high levels of acuity in our environment, where we have on-site nursing care that can provide that into people's homes or into our high acuity environments. I think also the investment you're making in the palliative support to allow people to palliate, to die in their homes and in their communities rather than hospitals is a really positive step. I think the tension in that is how you work through the existing model and transition into the future. And I think there's a lot of work to be done in unpacking CHISP and how that plays through into the models into the future. And I think the other thing I guess we would say in our sector is a lot of our residents pay for a lot of those services already through their general services charges. You do have home care providers that are coming into our community. We do think there's an opportunity to pool some of those funding models to be more efficient in how you might deliver those services. I think the other thing that's encouraging for me is that broadly Australians shouldn't and are able to pay for the accommodation, and I think that where they can, they should. I think the models of introducing percentages of allocation of that capital and a cost associated with that is good, because I think it's a lot of pressure we are putting on the taxpayers of Australia for Australians that can support themselves.
Thank you, Dr. Robinson. Can I ask about your organisation's policy on exit fees, noting that this bill does not allow aged care exit fees?
Yeah, we have arrangements where we, depending on the legislative environment, will enable people to access a daily accommodation fee or a funding model to allow them to get support until their excellent entitlements will be realised. So that, depending on the state, could be 6 months, 12 months. But we basically fund the daily accommodation fee until the home is either sold or we buy it back.
Can I ask you, Mr. Gannon, sorry, I'm just checking I'm not accidentally demoting you or promoting you, from Mr. to Doctor. Can you talk to us about the operations and developments you've seen in the past decade in terms of the aged care community and how you see this bill facilitating new developments and innovation into the future?
Yeah, thank you very much, Chair. Every year the RLC, together with PwC, produces a retirement census. And I think what's really interesting over the last couple of years, when we look at the question of whether home care is provided in the retirement village setting, what we've seen between 2021 and 2023 is a massive increase in the provision of home care being provided in the retirement village setting. So back in 2021, 30% of operators reported actively providing regulated home care services to residents in their village or to people outside that village. That's now doubled within 2 years to 61% of operators now providing home care. So we are seeing an incredible evolution of the retirement living industry that, 30 years ago was a sector that was traditionally focused on property and real estate. It's now an industry that is very much focused on the continuum of wellbeing, care and support services, which I think is the immense opportunity for the federal government, at a time when care is becoming really tricky in the community. There is an industry that is already providing the type of care that is quite helpful to the Australian government, and doing it, as Dr. Robinson said, with a user pays model that is very well known in this part of the property industry.
Sorry, Senator, just to run from that, 75% of our residents, if you don't have some sort of provision of care or availability of care, will ask questions about whether that's the right environment for them. So it's a really important thing from a consumer's perspective to have access to or support relating to care delivery.
So we think it's hard. When we're talking about the future of care, we don't think it's possible anymore to consider the future of care without considering the great value proposition that retirement villages play in that landscape.
Thank you. I mean, one of the things this bill seeks to do is sort of have choice and control at the centre of older people's care, and particularly their aged care. I'm interested in your perspective on the importance of choice and control and what those choices might look like and should look like for older Australians.
Look, I think the consumers are driving this, which is fantastic. So The consumer-directed care model of home care is what we see every day. So consumers will choose when and how they might want to receive their medications, their support, their meals, their clinical services. And I think that the challenge I see from a clinical background is the hospitalisation of aged care and the unpacking of what that means from an efficiency perspective. And that, where, I will give you your medications now, I will shower you now, you will have your meal now. And to shift culturally to I will have my meal now, I won't have a shower then, I might have my medications then. And it's how does that cultural change come through and wash through our system, which our consumers are wanting and asking for. And I think that's probably why we're really encouraged by the recognition of the RV sector into traditional aged care and the future of it. But we're a bit anxious about that sort of cultural overlay or risk, which is why we're really interested to see how the next sort of 4 or 5 years play out. We are certainly, as a registered home care provider ourselves and a deliverer of packages, we see the consumer-directed model is working really well from our perspective, from our customers' perspective, but I guess the test will be how this then plays out into the future of aged care and its delivery.
Thank you.
Which
Yes.
in many ways underpins a document that we've tabled with you this morning called Shared Care that we socialise with the department and parliamentary stakeholders at the start of this year. For a long time, obviously, consumer-directed care has worked effectively. We think that we've come to a point in time now where there is an opportunity to broaden out where that care is being delivered, not just to consumers but to operators of retirement villages at the same time that are registered home care providers, for example. The pooled funding model, the pooled funding concept, the average size of a retirement village is 100 independent living units with about 120 people living in those communities. So what those communities prevent is scale for pooled funding to get in there in a really streamlined way to make sure that more older Australians are getting more care per dollar invested in a really clever setting.
As an example, one of our villages in Adelaide called Tea Tree Gardens, where we have about 70 residents on home care packages, they can receive through their home care models taxi vouchers. We could buses, and there are other ways that we can still get people about, but again, because in the narrowness of the thinking, clearly they're wanting to accommodate people's ability to get around, but we don't need to have 70 cab vouchers if we need to take people to the shops for a day. Or there are things that if we actually unpack what actually happens, it could be far more efficient for the government and how it delivers its funding.
Yeah. Okay. Thank you, Senator Ruston.
Thank you very much. Just in terms of the Royal Commission's recommendations around making sure that Australians have a sort of a more seamless and streamlined sort of journey of care as they age, I'm keen to understand from your perspective. Obviously, you sit in the retirement living space, so you're governed under acts that sit within states and territories. Then, of course, you start moving into some of the aged care areas, which that integration obviously is going to be demanding. You move into a federal space. Do you have a view about ways in which government legislation or regulation might be able to be improved to allow you to be able to provide that seamless journey of ageing more efficiently and effectively through the model of your model of care?
Just before you answer that, could I just ask, we've got some witnesses on teleconference who aren't on mute, and it's just making it a bit difficult for broadcasting. So if you are online, could you just go on mute?
Sure, wonderful. So the retirement living industry intersects with a lot of pieces of state-based legislation. There's more than 30 pieces of legislation at a state and federal level that govern accommodation that's available to seniors right around the country. One of the concerns that we've raised with the department over the last couple of months is definitely the intersection between state-based Retirement Villages Act's legislation and the new Federal Aged Care Act to make sure that that red tape isn't stifling the sort of industry innovation that we're seeing in the market right now, which is actually providing a lot of the care deficit that's not currently getting out to older Australians. So that's definitely some caution that we would put forward to the Parliament about making sure that red tape isn't getting in the way of the sort of care innovation that's taking place in the market, like with Retire Australia, for example.
I mean, it's a great question. I'm new to sector, and I came in and I sort of stood in the helicopter. I could see that if you were starting from a blank canvas, you'd never build it the way we have. When healthcare started through the clinical environment, through the 1900s, the mid-1900s, non-for-profits were providing a lot of hospital delivery, and then effectively nursing homes became a way of managing residents that were non-acute and needed to be accommodated if they couldn't return to their homes, and therefore it was captured under the future of aged care, of healthcare funding and aged care funding. So you can see how aged care evolved, but then at the same time in the 70s, families like Daniel's were building these communities that were effectively, for downsizers in their mid to late 50s. And what we've seen in the last 30 or 40 years is this sort of convalescence of those two, and they've become closer together. And no one stepped back and said this one was regulated by the state governments, one by the federal government. And what we're seeing is that it's the same resident. The average age of our communities are 82. That's the average age of all the residents who live in Retire Australia. Those people are looking and are being supported by the same system, but the two aren't communicating and connecting enough. So we've got 250 in aged care, 250,000 in RV. It's half a million people that are all the same people. It's just they're intersecting into the sector differently. So I think if we were blank canvassing this, like the New Zealanders have, where they have one regulatory oversight, you'd do it very differently, and you'd have it in intersecting, connecting right through the resident's journey to end of life. And then how our regulation would oversee it would be very, very different. But we're obviously dealing with two very different systems, which puts us at odds at times.
Yeah, I suppose I'm sort of just trying to think it through. Your shared care model obviously is sort of that choice and control that delivers to older Australians is so important, because we talk about choice and control and then we regulate it to an extent that nobody's got any choice or control, and that includes the resident. But so I'm just sort of keen to understand with this sort of like journey and the move towards actually having residential aged care co-located and supported independent living, then into residential aged care co-located. How do you make that journey seamless? Because clearly you're going to have designated areas that come under the Federal Act as soon as somebody moves across into that area.
Yeah.
Is this a classic case of designing a camel? Could we?
I guess we're pushing from the RV. So we are currently delivering private aged care models under the Retirement Villages Act with home care services that are doing just that. So we're building small house models that are 9C standard, that are providing 24/7 upright nursing care and palliative care for residents, either to fund fee-for-service or use their home care packages. But we're anxious about taking that next step because of the concerns that we get trapped in a non-consumer directed environment. So this is the tension about, we're innovating, we're pushing into the sector, but we're really interested, and we've had Nick Hartland up to the village. We've shown in the model. He can see what we're doing. It's just that to get scale and to get operators to really invest and push into that, I think there's how do we create less concern about the risk of compliance and other things suffocating how you deliver to a consumer as they would like. That's the tension, which I think will come over time, but how do we unlock some of that? And that's what's interesting about the RVs being included in the Act, but clearly still to deliver aged care services, you still need to comply completely with what is expected, which I understand, but that's also a risk in people's confidence to innovate and invest.
So 44% of new retirement villages around Australia are being delivered with co-located aged care. 44% at the moment. But at the same time, you can count on any one hand in any jurisdiction around the country the new resi aged care facilities coming to market in a development sense.
Non-for-profits, Anglicare and others are really pushing back from traditional aged care models into their RVs. So the strength that they have is they're competent and capable of delivering aged care. They also have home care and they have a care culture, but they see the opportunity sits inside the RV environment because of the product being independent living with care. So they are probably it's a big opportunity for them. I guess the tension also is equally for operators like us. How do you enable us and support us with confidence to push back into providing higher acuity services as well, safely and clearly governed properly, and have big capital partners come in and do that and fund it, because ultimately this stuff costs money and we need really high quality ethical shareholders and capital partners to do so.
Yeah, because I mean, if you have a look at some of the models that I've seen over the last 2.5 years, I mean, in some of the retirement living environments, you actually have almost got an residential aged care operation running because of the way that your services are being provided. I'm just sort of interested to understand are we over regulating unnecessarily in residential aged care? If we could actually take a little bit more of that flexible model that you are applying, is it LDK?
LDK doing great stuff in Canberra.
I've got to say, one of the funniest afternoons I've had speaking to the residents out in Tuggeranong, but I've never seen so many happy people in one place in my life. Yeah. And for them, it seemed like when they had made their investment to move into that particular facility, they knew that they had a feeling that they were there for the rest of their life. Yeah. There was no sense that they were going to be there and then they were going to have to go somewhere else. So what is the opportunity by the new legislation, and is there something that we could put in the new legislation that would allow older Australians, once they'd made that sort of downsizing decision, that they could actually feel the way these people were feeling at LDK?
I think probably the opportunity for me is to look at, in the referencing to RV and being able to provide services inside an RV, do we have, is it necessarily needing to be as restrictive or compliant to frighten operators off to deliver? Because what LDK are choosing to do, ourselves, Odyssey, some other operators, say, okay, we're going to sit within the RV environment, but within the home care model and leverage home care packages, but also fee for service, because we feel that's truly consumer directed. The anxiety about taking the next step is the constraints that it provides on the delivery of consumer directed models, whilst it's effectively, as you've seen, it's aged care.
I mean, only the reason I ask this is because sort of you look at a lot of the people that you are dealing with, and certainly the people at LDK and other places I've been to, I mean, they have a reasonable wherewithal in terms of being able to financially contribute to their support. And how does that then sit against those that are unable to be able to afford to be able to access this new and innovative model? And where does that leave our aged care, residential aged care providers in terms of becoming, to some extent, the poor cousins of the aged care sector? So I'm just really keen to make sure that we, that true choice and control is offered to every Australian within their means to be able to get access to it. I mean, do you have, I mean, there's no such thing as a supported resident in retirement living, is there?
Well, so communities like Lincoln Grove here, incredibly affordable environments. We have many pensioners that are able to sustain themselves, to fund themselves and their care services. As I said, we have 6 or 7 of those communities across Australia. But, you're equally as right. If you look at the village that we've just opened in Brisbane at Tarragindi, where we provide home care services, the average age of an ingoing apartment there is $600,000 to $700,000 for a 2-bedroom apartment. So that isn't for everybody. So I guess just as your point about the tension of people being able to afford their accommodation with means, and then the funding of their services, and how is that more equitable? I guess the way I look at it from a healthcare perspective is private versus private insurance, and the ability for those that can do that enables government to support those that can't. And so I see the RV environment particularly as an opportunity for government to have the Australians that can afford their accommodation and care services and pay for them to do that, to take the pressure off the cost of that burden on the aged care system more broadly.
So maybe just a couple of details, I guess, in context for the sector. 30 years ago, people who were 55 were moving into a retirement village. In fact, I met Denise this morning up the road at Lincoln Grove. She moved into that village 22 years ago. She's 75 today. Today, the average age of entry into a retirement village anywhere around the country is 75. They're spending on average 9 years in the retirement village. The average price of a 2-bedroom unit is $559,000, which is 43% on average cheaper than the same house across the road in the traditional real estate market. Now, at the same time, there are different contractual models that are attached to retirement villages. But for a median house price of $559,000 anywhere in the country, that's not for everyone, and we're not saying that retirement living is for everyone. Just under 13% of people over 75 live in a retirement village. So I guess the message from us to the government is housing markets are about diversity and choice. We think retirement living is playing a really important role at the moment. We think that it could play an augmented role moving forward in the event that in some ways less red tape, not more red tape, is attached to the delivery and provision of care when it comes to getting home care out into the market.
Mm. Okay. In your submission, you make a comment that in your consultation with the bill, the key message had been to meet the significant demand for aged care services, and these reforms facilitate new and innovative models for the provision of care and not impede them. I'm interested in your not impede them. Is that a code for you see that currently you are being impeded?
I guess that's where I was, using the example of the new village we built at Burleigh on the Gold Coast, where we have 150 independent living apartments with what we call a 10-bed care hub. That care hub is effectively a private aged care offering, but where user pay services or home care packages are leveraged. We hope that very few of the residents actually need to move into the care hub. The intention is that the care hub is where our care services radiate out to the community, so people in their 2 or 3 bedroom apartment can receive all the care they need, including palliation to end of life. For those that can't, and we only just had this week a first resident of that village move in because the lady's husband was really struggling with his Parkinson's. He's now moved into the care hub. She's maintained independence in her independent living apartment there. They're 2 minutes walk away from each other, so we're keeping couples together, families together, but in an environment where we're tapping into those funding models. And it goes back to that conversation about the environment of this new Act, and does it really enable us to truly deliver consumer-directed support? And that's the question that operators have right now. So we are really watching with interest. We've built our private aged care model to a 9C standard. We could come and apply for a licence today under the changes, but we're holding back to see and to understand more to ensure that we're not in any way impeding from delivering a consumer model.
So when you're saying you're standing back and waiting to see, you're waiting for the rules around this Act, or you're just waiting to see how it plays out once the Act's been?
Yeah, we're just waiting to see when it's implemented, what are the implications, what are we observing. We are able to move quickly if we choose to, but we're not launching at the moment. So and LDK would be doing the same. So we're observing. We feel that the home care model allows true choice and independence. We're not sure is that going to be enabled through this bill in the context of delivering publicly supported aged care.
Okay, so what is raising those concerns in the bill? Is it something that's in there or an omission? Just compliance-related issues. The expectation of minimum hours of nursing, and it's quite a rigid conversation when you say, well, how could we deliver care and care support differently? Are there ways that this can be through RN support? Could it be through a personal care attendant? I guess the constraints of some of that we're interested to see play through. We would actually comply, but we just have my head of operations has been in the sector a long time and just would prefer for us to wait and see before we launch.
We are due to move to the next panel, so I just wanted to check if anyone online had questions. Any senators online? Just to be clear.
Taking calls.
Yeah, that's right. Let's not talk back.
North Haven.
Okay, thanks, Senator Kafasik. Look, with your agreement, Senator Ruston, we are due to move on, so we might leave it there. But thank you very much for your appearance before our committee today and for your evidence. We really appreciate you being part of this process.
Thanks for having us.
Cheers.
Bye-bye. Thank you.
Safe travels home.
Yeah, you too.
And the rest are online.
Sure, we'll be on the same flight this afternoon.
No. Oh, yeah, probably. No, I think he's going out at 2. Because they came in with us this morning. Well, you know that they were sitting one behind you and one in front of you.
Okay. Catherine, I believe it might just be you in person with us and everyone else is joining via video conference. And that's okay. I think we're ready to go. All right, we'll now be moving to our next panel, which is another lived experience panel, and I'd like to welcome all of the witnesses who are joining us to provide their lived experience today. This session is an opportunity for you to make a statement to the committee, and it's really a listening exercise for us. So you won't be expected to answer questions from senators, but we are asking you to share your story and your experience with us, and we'll be listening very closely to that. I would like to remind you not to disclose any personal or private information, such as your date of birth or your address during the statement. That's because the audio of this hearing is being broadcast live. We don't have the opportunity to stop it going out once it's been spoken, so just please be mindful in terms of the information you're sharing. I'd like to ask each of you to please state your first name for the benefit of the Hansard transcript. We'll start with Catherine in the room.
Hi, Catherine.
Thank you. And via teleconference, I believe we have Joe.
Yes, hello, Joe.
Thank you. We have Peter M.
Hello, that's me, if you can hear me.
Yes, thank you, Peter. And Peter W.
Yes, it's Peter here.
Yep, thank you very much. And Gwenda. Perhaps, Gwenda, are you there? Okay, looks like we might not have Gwenda.
Gwenda was on the line before, so it might be worth trying.
We might see if we can get
online.
We can get Gwenda back. So I'll invite you each to provide your testimony with us. Towards the end of the time you have, you'll hear an alarm sound. That's just to give you a gentle reminder to please start closing your remarks because our time is limited today. But we'll start with you in the room, Catherine, if you'd like to begin your testimony.
Okay, not sure what I'm supposed to be delivering, but here goes. My background is I hairdressed at Matthew Finder's for a number of years. I care for my partner and I work for Carers SA. I'm now on the board at West Coast Home Care. My big concern about all of this is right back at the start of it, how do aged people start the process? Is it online, by telephone, face-to-face? Because I've found over the years people that are confronted with online or phone, it's distressing to them. They're not coping with having to do that. Is there any indication whether or not you could do a face-to-face like an ACAT team does? And a lot of the holdback from aged people doing online stuff is they're brought up in an area that touching buttons was not allowed in the home or anywhere. It was against the rules. You didn't do it for fear of breaking. Now when you present them even with a phone, they're worried that they're going to break it in some way. And to me that needs to be understood on a ground level coming through.
We've got Joe via teleconference.
Sorry, you'd like me to speak?
Yes, please, if you'd like to make a statement.
Yes. Hi. Yes, my name's Jo, and I have background as being a site operations manager in aged care. I have experience at the moment delivering a transition to practice program in aged care, and I also work with one of the unis where I co-developed a dementia care pathway, and I have some background with ANMS too, which is the union. And I think, and I'm very grateful for all the reform the government has done in the aged care sector, but I am still really concerned that through my current roles, I'm still seeing and hearing issues, particularly around staffing and skills mix and the ability for people, the workforce, to still be able to advocate for that within their workplaces. I'm hearing there are not enough staff on shifts. We've got new nurses that are having to allocate care without enough staff, and that's causing them obviously a lot of stress in how to provide that care for older people. And it is a little bit expected that you will work short. There is a that is what I'm hearing out there. We're also hearing a lot that aged care providers are not replacing the EN roles. So I hear from a lot of enrolled nurses are really concerned about their positions, particularly in South Australia where I work. And it's not necessarily a full removal of that role, but it might be things like not replacing them with an enrolled nurse lead. And then the flow-on effect of that is where there is additional responsibility then on the registered nurses and also on the personal care workers. And, at the moment, with the new Act, the personal care workers are still not regulated workforce. And, we're hearing things still that, medication administration is being delegated to care workers. We've even heard that sometimes some organisations are looking at upskilling care workers to do things like wound care and clinical observations. And, that's a really real risk to older people that they're not getting good clinical care. And in the Aged Care Quality and Safety Commission, medication complaints actually still remain the highest risk area as well. I think with this, we also know with the care minutes, which was brought in, which was fantastic, but I'm aware that a lot of the recent data shows that the aged care facilities are not meeting their required care minutes, with not really at the moment any real regulatory consequences for this. And so it's kind of, it's really undermining that quality of care because it's not really making it important enough. So it should be important enough to regulate if it's in the Act to make sure that there is the appropriate staffing and skills mix available. So I think I'm still hearing that despite the reforms, we've still got nurses being registered and enrolled and personal care workers. They're still struggling at the coalface and there still is short staffing and there is a lack of skills mix. And they really, through the Aged Care Act, there's no real power for them to advocate on behalf of themselves and obviously for older people. So I think in terms of my statement, it would be hopefully the Aged Care Act is that opportunity to make sure that the quality care is provided, but it is reinforced through the care minutes and also through the ability of workers to advocate on behalf of older people to make sure that they are receiving quality care. Thank you.
Thank you very much, Jo. I'm going to go to Peter M. Peter, are you there? All right.
Can you hear me now?
Yes, we can. Thank you, Peter.
Okay, so I had it on mute. I'm Peter M. I live in Adelaide. Thank you for the opportunity to speak. I'm a home care package recipient and volunteer advocate for assisting people navigating the system, assessments and selecting and getting set up with a provider. I also manage 3 home care packages as well as my own. My comments basically relate to the home care package and the supported home system. Firstly, I'd like to comment on the capped hours for cleaning and gardening. This does not take into account that a person with high own needs cannot do these things and need more hours. It's stated that these things we have always done ourselves, but as we age, we can't do them. The higher needs a person has, the hours need to be increased. The other thing I wish to talk about is client contribution. As a general statement, and I'll attempt to put some support to that, the full pension of the recipient contribution is not affordable and should not be charged. I've done a financial budget for one of the people whose home care package I manage. It shows that with client contributions, there are $35 in the red per fortnight. This doesn't take into account things like clothing, car repairs and other expected repairs and replacements. They are, at the moment, they will currently be unable to afford any social activities. The client contributions are $170 per fortnight or $4,500 per year. Look, that clearly shows that a full pensioner is struggling to live even without the client contribution. The situation is similar for a full pensioner who owns their own house, with the added expenses of that, and for many part pensioners. Both of the two areas I've just discussed are ill thought out and do not take into account both the actual recipient needs and their affordability. The basic principle of supported home is to assist people to age at home. With the limitation on hours and recipient contributions people are going to end up paying, they're going to end up in hospital or residential care. Onto a different subject, the care management reduced to 10%. Quite confusing to me and many other people. There's a problem with this in the Act and the supported home system. Care management has been reduced to 10%. Providers are to make up the difference by adding to the worker hourly rates. There'll be maximum hourly rates set, but they are not yet published. There are no controls proposed to control what providers can charge and ensure the overall charges do not exceed or are less than what they currently are in the home care package. It even becomes more complex with self-managed providers where recipients find their own workers and each could have a different hourly rate for the same type of worker. The cost of upgrading provider computer systems with these would be huge. Given there is no controls of what amounts providers can charge over worker invoices, and they have to recover, or the government will have to pay towards a new computer system, it's likely that these proposals will cost more than the current system. There is no explanation of what this charge is trying to achieve. Is it trying to control the charges of providers? Because as it looks at the moment, providers are going to be able to charge more and recipients will be the ones that suffer by potentially higher worker costs. Frankly, I don't see the purpose of this proposal and what improvement it will achieve. And in closing, I'd like to have just make a few words relating to the Safety Commission. The proposed aged care complaint system is not going to work any better under the new Act. So many people have struggled to get a provider, especially to follow the standards and rights of care for older Australians. But what we get told by the Safety Commission is that they cannot make a provider do anything. You can complain, exactly, but basically the providers do not have the power to make a provider do anything. We get no transparency. There's no transparency in this Safety Commission. As a result of their complaint, they simply close it on us with no result. They cannot enforce any particular penalty to a provider. The Safety Commission needs to be a completely independent body that can apply enforceable consequences to providers who fail to do the right thing. Deterrents, such as criminal and civil penalties, which were in the Exposure Draft Act, must be put back into the Act. Just in closing, I hope the committee takes into account our experiences and appreciate with all the recent changes, there has been little to no recipient consultation or input. I'm somewhat disappointed there is no provision for the committee to put questions to us, however that's what it is. Ageing support is supposed to be at us. That's my lot. Thank you.
Thank you very much. And we have Peter W. on the line as well.
Hello, I am Peter W. You can hear me okay?
Yes, we can. Thank you, Peter.
My volunteering began in 1966 with Meals on Wheels, later as a driver, community visitor and advocate. I've served in committees with the Aged Care Quality and Safety Commission on clinical standards and with the Department of Health on the integrated assessment tool. I was 65 when the NDIS started. I'm a self-funded retiree with moderate resources, and I contribute to my home care package. My independence is supported by a power wheelchair and a home respirator. I live with heart failure and severe respiratory disease. At the age of 4, I was held down by 2 nurses on a cold stainless steel table while the doctor injected a needle to drain spinal fluid to reduce inflammation. I did not see my mother for weeks. When I did, she was behind a glass door. Through my feverish stupor, I fleetingly recognised my mother waving a parcel wrapped in brown paper. I awoke later with the brown wrapped parcel out of reach on my bed. It was my rubber duck from home. After my bath, I was removed by a nurse, hooded from head to foot in protective clothing, and was cried to my bed. I was told I was selfish. My duck had to be shared with others. My rubber duck would have been destroyed as a potential carrier of the polio virus. I was luckier than most. I only spent 3 months in hospital. Residential care is terrifying for people with memories of being stolen, forgotten, abused, abandoned, or isolated in trauma. Residential care is imprisonment for people with disability denied access to their customised environment and the aids that kept them independent. For people with ME, CFS and other environmental immune diseases, the thought of the exposure to the petri dish of residential care is terrifying. Section 25(4) of the bill before you reads, the Commonwealth Aged Care System offers accessible, culturally safe, culturally appropriate, trauma-aware and healing-informed funded aged care services, if required by an individual and based on the needs of the individual, regardless of the individual's location, background and life experiences. Yet where are the mechanisms? Consumer-directed care has been removed and the single assessment tool does not respond to trauma or special needs by recognising flexibility in services to meet individual needs. Supported home is riddled with caps and contributions despite many of the services previously common in practice. The 2024 Home Care Packages Assurance Review number 4 excluded items revealed a total of 300 excluded items, approximately 1.2% of HCP funds. 1,824 care recipients had a total expenditure on excluded items of $124,466, an average of $68.24 per care recipient. Calculated across all HPC recipients, the total value was around $17.6 million over 3 months, or $70.5 million a year. In 2023-24 financial year, $7.7 billion of funding was allocated to the HCP program. I note that 5% of the total expenditure is insignificant compared to the cost of fully subsidised residential care. Supported home must do what it says in name. Most excluded items are jobs once done by the recipients, such as low-cost home care maintenance, unlocking drains and toilets, fixing leaking taps, cleaning the home water tanks in rural communities. Supported home must include GP allied health recommendations for non-PBS medication and essential care products. It is not hard to find out what should be on the list, and it is not hard to identify hardship. An option to not explore, to my knowledge, is a 3-monthly supplement of $500 to pay for out-of-scope services for people with higher needs or experiencing financial hardship. It is a flawed argument that people in deep need don't appreciate things they cannot pay for. Most people wouldn't be embarrassed by seeking help, and most will be humbled by the care offered. Individual contributions, a tax on frailty, wrote Commissioner Biggs. A hypothecated tax or levy was recommended by both commissioners to be referred to the Productivity Commission. Yet the time-constrained aged care task force recommended that all baby boomers pay. Where is the economic modelling and what are the other options? A single pension is $1,144.44 per fortnight, just shy of $30,000. The average Australian family struggles on an income of $160,000 per annum, $116,000. 1 in 5 families have incomes in excess of $250,000. The Aged Care Task Force noted, in effect, that 88% of the 280,000 home care package recipients are income assessed by Service Australia as not having the means to contribute to their home care package. Pensioners and people on low incomes can't pay upwards of $95 per fortnight. An interpretation of the Act before you is that providers must continue services where contributions remain unpaid. Current income assessment is hard and it lacks equity with those of good health, but it is far more equitable in forcing individual contributions on people who cannot pay. This Act and program is an imported and outsourced global model of failure to recognise individual need as unique. The Act can be fixed and there are people of good intent, but by golly, this Act should not be passed by Parliament until all facts are known and published for public scrutiny. Providers, financiers and those ensuring in-house governance cannot prepare new systems without a profound understanding of all the rules, pricing, grant, subsidies that will not be fully available until February 2025. The earliest that support at home can start is the 1st of July 2026, not 2025. So don't rush. Let's get it right. Adhere to the advice of the Royal Commission and ACOS that a levy would reduce the likelihood of a two-tier system where high-quality care is only accessible for those who can pay the most. I thank you, and I'm open to questions.
Thank you, Peter. Gwenda, I believe we've got you on the line now. Would you like to make a statement?
Thank you. Thank you, Senators, for the opportunity to speak. I first received a home care package in the beginning of 2024 in 2014, and I've seen lots of changes through the years since 2017 when they introduced consumer-directed care, and I've followed the journey of the current proposed supported home program. Please be very clear, I'm speaking for myself as an aged care advocate and activist, speaking in my own experiences and what I've heard from older people. I'm not representing any organisation. I said in 2019 to the Royal Commission in the home care system was broken. And here I am in 2024 saying it's still possibly a much worse condition in 2019. We have a chance to fix that, but we have to get it right. I and many others I've spoken to acknowledge the need to improve aged care for all Australians and provide a critical foundation. Sadly, the Act does not mention LGBTQI+ or other diverse communities, but I do welcome the continuation of that CFAC funding. Fixing a broken system starts with the legislation of the new Aged Care Act and then the implementation. Not exactly as proposed, but with some amendments that I and others are suggesting. We must get this Act passed into law as soon as possible to ensure the rights of older people are upheld, and then we can get on with the implementation of various sections which will need amendments or adjustments in delivery, with a review ideally after 3 years, not 5. I welcome strengthened regulatory mechanisms, the introduction of more robust oversight and accountability mechanisms, including civil penalties and stronger governance through the Aged Care Quality and Safety Commission. Chapter 3, Part 4, providers must ensure requirement prescribed, but there is no mention of aged care workers. I'm concerned that there will still be not enough regulation and registration of workforce. Workforce, particularly for self-managed home care, remains unregulated and leaves older people at risk of untrained workers delivering services. The appointment of an independent complaints commissioner is very welcome, as is the First Nations Aged Care Commissioner. The question is, where do they sit? They must not sit in the department or with the regulator, so I suggest it's legislated they sit with the Human Rights Commission. The bill introduced a single assessment pathway, which will introduce complexities of accessing aged care services for older people and their families. However, the assessment tool since it was introduced has not been working effectively, and assessors are still manually completing the algorithm. I've spoken to several different assessment organisations, and it concerns me that not always are all the assessment tools in the toolbox being used. Imagine having a toolbox with a hammer and a screwdriver and only ever using the hammer. I'm concerned that the kicker is not being used to assess cognitive decline in Aboriginal and Torres Strait Islander people. How an older person transfers today may not be the same as yesterday or tomorrow. Older people deserve to be listened to and assessed alone, as well as with their carer or loved one present. I am also concerned at how gardens can be maintained in 18 hours per year or 21 minutes per week under supported home. This will put many renters at risk of eviction. Gardening for many is an essential part of their social and emotional well-being. For that matter, how much can 1 hour a week maintain a clean, safe environment for healthy ageing at home? Waiting for 6 months to get an assessment and then for 9 to 12 months for a package to be assigned, while many are in chronic pain and debilitated from various age-related decline, is unacceptable. This is forcing people onto waiting lists for residential aged care places that do not exist. With over 70% of older people entering residential aged care malnourished, we have another shortcoming in home care. Government subsidised meals of highly processed, tasteless frozen food, or even Meals on Wheels, who we heard from on Friday, is not good enough. We heard on Friday from Meals on Wheels that they come as a package. You must get that package. Usually the cost of around $22 that is government subsidised, and the recipients pay $6.60 per day. That's a super, main meal and dessert. It's often jelly or a childlike container of chew fruits. This is not adequate, and most do not eat the soup or the dessert. So therefore we're ending up with people malnourished at home in Australia. While as a renter who receives a full aged care pension of $1,144 per fortnight, plus $211 rent assistance, which is $1,355.20 a fortnight, I acknowledge the need for co-contributions and support co-contributions. If IACPA agree on, say, $100 an hour for independence, I do not consider $5 an hour to have a shower too much, but I must be able to have a shower a day, 7 days a week. $17.50 per hour or $35 a fortnight for everyday living could be affordable if the service was delivered effectively. Aged care needs to be funded whether by home care package recipients, RADs or daily accommodation payments, but there needs to be clarity of the amounts expected to be contributed. Is not personal care a clinical service or an equivalent to an allied health service? The proposed 5% for one service and 17.5% for another is very confusing for older people. After a shower, personal care, the bathroom needs to be cleaned and tidied. A wet bed often needs to be changed and laundry done. How do we delineate between what's charged as independent at 5% and everyday living at 17.5%? This is not a perfect bill, but it's far better than the current Act. Older people have the right to high quality support and services, and you have the power to make this happen. We want all older people living active, self-determined, meaningful lives to their maximum potential, supported to do so, receiving services they choose, when and where they choose, which is usually in their own home. Of course, this means the rights of older person to have intimate relations in residential aged care. You thought you got away with me from that one. And for people living with dementia to be able to go for a walk if they want. Let's meet the unmet needs of people living with dementia and stop labelling them as behaviours and using psychotropic medications for staff convenience. We must also consider transport. People living in rural areas cannot use community transport. They are travelling 2 hours each way for dialysis or chemotherapy or treatment in a bus, and they have to wait all day following treatment in a hot bus. This is unacceptable. We are talking about funding thin markets, but there are no taxis, so support workers are necessary and are required for transport. But maybe 6 to 8 hours a day at 17.5% is at, say, $100 an hour, is $105 or $140 a day. If you have to do that 3 times a week for chemotherapy or dialysis, it's basically denying healthcare. I ask you to support the passing of this bill, but let's look at the amendments closely. Thank you for listening to me.
Thank you very much, Gwenda, and I'd like to thank all of our witnesses for their statements. As I said at the start of this session, this is primarily a listening exercise for senators, an opportunity for people to share their lived experience with us. However, Peter W., I noted you said you were happy to take questions, and Senator Ruston did just have a couple of questions for you. So if that's still the case, Peter W., I'll pass the call to Senator Ruston.
Yes, certainly.
Thank you very much. And can I obviously add my thanks to the Chair for everybody on both of our panels today who've come forward and made a contribution, but particularly can I acknowledge the extremely thorough submission that you provided, Peter W., and can I put on the record also that Hannah and Peter F. this morning, it seems to be a day of Peters, they also made very thorough submissions, and acknowledge and thank them for the huge amount of work that they've put in before even getting here today to prepare their submissions. So, Peter W., I was just wondering, you made a comment during your verbal submission a minute ago about how you believe that the Act should not be implemented in 2025, but in 2026. And I'm just keen to understand from you what your key concerns are around, from a consumer perspective, what your key concerns are around that and needing that extended timeline.
Essentially, that's one that's obviously the suppliers just don't know what they're doing. They haven't had a chance to analyse the rules in fullness. I know that many of the rules will be open for interpretation, and that shouldn't be the case. It's already been mentioned that the Aged Care Quality and Safety Commission struggles to enforce certain things, and I think we need to look very carefully at the way that's handled. And I don't think this Act really covers that, and I'm not too sure what's in the rules. For example, if a complaint's put through to the Aged Care Quality and Safety Commission about something such as bed sores, surely the first process shouldn't be going to all the legal side of it. It should be ensuring that medical care is immediately provided to the resident, and assessment is made and a plan put in place to provide whatever treatments are needed. And yet that's missing from the process of a complaint. They don't even know if the complaint's genuine at that stage. And without knowing how this is going to be supported in the rules, it's impossible for a provider or an advocate to know exactly where they're going.
Yeah, thank you. And I just should let you know, Peter, that we've heard from a lot of witnesses around their concerns about the ability to implement within the time frame from lots of different perspectives, but acknowledge that from a consumer perspective, you see this challenge as well. Now, am I correct in your opening remarks and also in your submission, you mentioned forgotten Australians, and I was just wondering, yes, given that we are heading into a time now where a lot of people who were subject to institutionalised abuse are now reaching an age where they are likely to be needing aged care services. Do you have a view around things that could be done to ensure the appropriateness of the aged care provision for this particular group of older Australians who, for very obvious reasons, have great hesitancy about anything that's institutionalised?
I'm hesitant to say any more than it will be up to individual assessment. People who've gone through trauma, some of us can manage it, and some of us are revisited by it unexpectedly. And that's why I told my story. I can't tell you stories of what it's like to be a part of the forgotten generation, but those who I've spoken to are suffering exactly the same sorts of trauma that I was exposed to, and many of my friends and colleagues have been exposed to as children. There's not one solution. I would, however, recommend that every effort is made to support those people in their own homes and in their safety of what they've built. And I don't think this program is able to do that in its current form.
Thank you very much, Peter. Really appreciate your sharing that with us. Thank you, Chair.
And I'd like to thank you all again for taking the time to participate in our process. We really do appreciate those who've made written submissions and joined us today to provide their statements and their evidence. So thank you very much. You're free to jump off the call now if you wish to. The committee will now take a short suspension and will be returning at 2:45 p.m. with Curtin Heritage Community Living. Thank you. Welcome representatives from Curtin Heritage Community Living. Thank you so much for appearing before our committee today, and I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, could you please state your full name and the capacity in which you're appearing?
Cool. I'm David Cox and I'm from Curtin Heritage Living.
Great.
And I'm the Managing Director. I knew that's another thing.
Thank you very much, Mr. Cox. Did you have an opening statement?
Yes, I did. Good afternoon and thanks for the opportunity to participate in this really important process. I'm from Perth and bringing a really different perspective to the conversation today. Curtin Heritage Living is a not-for-profit, community-owned organisation. We've got residential care, in-home services, retirement living, and we also provide non-government funded community services. I'll talk about that in a minute. We're focused on the inner city suburbs of Perth, the inner city beachside suburbs of Perth, and we've got a little over 1,000 clients. We provide services to the very wealthy, but we also provide services to people that are with financial hardship. Our primary goal is simply just to provide the best care that we possibly can in the area that we are, regardless of wealth or circumstance. We pride ourselves in being really contemporary. We've got a really different approach to aged care. We also pride ourselves in being innovative. So we negotiated the first labour agreement with Home Affairs. We were the first to implement artificial intelligence into our care homes. And we've also got a really novel organisational structure that goes across the silos of aged care. So our staff are working across residential care, in-home services and retirement living. The delivery of services also goes across all of those spectrums. And we recognised some time ago that aged care wasn't going to be sustainable, particularly residential care, and we've worked hard to diversify our operations. Up until 2018, we were just a little residential care provider. We have commercial amenities, so we have restaurants, we've got a bar, we actually have a medical centre and art gallery tenancies, and we actually use that income to provide services to the wider community, so to fund services to the wider community, but also to cross-subsidise our residential care operations, which has run at a loss for quite some time. So we're really looking to seek alternative ways to actually fund our services without having to compromise quality. We really support this bill. We believe that the aged care statement of rights, aged care principles and the strengthened standards provide increased protections and clarity for providers and for our clients. We advocate for increased choice wherever possible and believe that this in turn will increase our quality of care for our clients. We support the new Support at Home program and are looking forward to the merging of CHSP as soon as possible. We, unlike other providers, want these systems in place as soon as humanly possible. It is disappointing but understandable that this rights-based framework doesn't extend to the universal right to access. The bill refers to a right to care, but the right of care really only is afforded to those that are lucky enough to actually access the services. We do welcome the recognition and importance of advocates, significant persons and social connections in the principles and the standards. Under the existing system, lifestyle activity and social support we think is very undervalued. In residential care, allied health and lifestyle is not explicitly funded or included in care minutes. We believe that this has compromised lifestyle options for older Australians, and we hope in time that this critical element of care will be recognised by way of changes in the new rules. We're keen to receive more information on the rules relating to the higher everyday living fees. We used to provide extra services to our clients, but we actually elected to cease this as the provision of services is highly prescriptive and didn't meet the needs of individuals. They simply didn't get value for money out of extra services. We actually have customised ad hoc services that are available on an additional service basis. We've got concerns that the requirement to always enter a written agreement for additional services will limit the capacity of residents to request and receive ad hoc services. We believe there should be specific provision in the Act that allows providers to change additional services on an ad hoc basis, in the same way that you and I purchase goods and services from vendors every day. We believe that this will benefit not only the people with significant means, but the people that are on pension that want the simple things that they had at home. Thank you again and welcome any questions you have.
Thank you so much, Mr. Cox. I just want to take you back to your comment about the use of artificial intelligence, and can you explain?
Usually grab.
Yes, how that's being used.
Yeah, so we sought artificial intelligence technology from Finland so that we can actually develop algorithms for individuals in their own rooms. Our residents want privacy, and so they want to lock their door. And traditionally in aged care as a nurse, we would actually walk in and look at them in their room. This actually affords us to actually avoid that. So the resident, if they choose to, can actually lock their door and actually have privacy at night time and have the security of AI actually looking over them. So we actually set the AI to determine different scenarios. So a resident might be at risk of falling, they might be at risk of going to a balcony, they might be at risk of going inside their bathroom, or they might even be at risk of UTI and going in and out of the bathroom a lot. And we can actually program the system to actually monitor behaviours without being invasive, so we don't see them on CCTV or anything like that. And it gives us some really valuable insights to aberrant behaviours, but also future care needs.
How are they monitored?
So it is actually sensors. It is actually cameras in the ceilings of the room. It actually looks at them, and then an AI software actually interprets that material. And then actually will send messages to staff. So if a resident, for example, is at really big risk of actually getting out of bed and falling over, instead of waiting for a traditional fallout mat where they're already out of bed, it will actually say this person is starting to roll, they're starting to wake. Should you actually go in and have a look at this person before they actually get out of bed? So it's actually decreased our major fall incidents, so incidents with injury, by 40% over the last 2 years. So it's been pretty amazing.
And do residents sort of happily consent to that? Is that something that...
Yeah, it's a really big issue. So and something we were really nervous about. So we go through quite a big education process and go through that story of why we're doing it. So it is to actually increase privacy and safety, and they explicitly consent to the use of it. So when we first started, all bar two or three of our residents consented. Now universally our residents have consented to use the technology. So some use it a little bit, say if they fall over. Some have a lot more programming involved.
Fascinating.
It's always the thing that grabs people. Yeah.
I mean, is that common in the sector? I mean, the use of...
No, it's incredibly expensive, and we're really lucky. We have a really modern integrated community. We're lucky enough to get RADs, and this is where I think our conversation is quite different today. Our residents pay exactly the same as every other, they're funded exactly the same as every other residence, but the RAD has afforded us to actually have the capital to actually invest in this technology that's not afforded to most other providers.
Okay. Well, I was going to ask you a question about your experience in accessing capital. But you want to expand on that? Am I here?
Yeah. So we're lucky enough. We have 2 residential aged care facilities, and both of them are in suburbs that are wealthy suburbs. So 30% of our residents pay no RAD, so they are supported residents, and some of them have discounted fees as well as part of our charitable aim. The other residents pay RADs, and those RADs range from $650,000 to almost $2 million. 90% of our residents pay the RAD, which is so atypical of the industry, and I think it's indicative of a population that has wealth. Because of that, it's actually afforded us to invest in capital. So we have built a beautiful integrated community. It cost $150 million. And that has been paid completely by RADs. So we went and got traditional debt. The banks saw that our debt profile was good because of where we are and because of the potential for people to pay RADs. So we didn't have we didn't have difficulty accessing funds. Again, a really different story to other providers.
Thank you, Mr. Cox. In terms of the 1 July 2025 commencement date, are there any barriers or challenges which concern you with that commencement date?
We think because it's essentially a staged process in residential care, because you have people that are grandfathered and then you have new clients that are going to go into the new system. We don't have any major concerns about starting on 1 July, to be honest. I think, again, we're lucky because we actually have systems to support us in terms of fairly flexible finance systems. We have a great quality system that's quite adaptable. What we do need is more information so that we can actually modify those systems and build them up. And so we're really keen to see more information coming out from the department, and we believe it's coming. Support at home is a little bit different. We're quite nervous about support at home, like I think the other providers have explained today. Again, there's not a lot of clarity at this stage, and systems aren't built to accommodate. We've just procured a new system, again, that's flexible, and we think that we can mould it into support at home. But until we actually see those complex and detailed rules, we won't really know. So we're hoping support at home will come a little bit later than what they're forecasting.
Thank you. And I mean, I know sort of some of the differences in the services that you provide or sort of your structure to others, but in terms of the increased pay for aged care workers that the government funded, did you see an impact of that in your services, and what was the impact of that for the workforce?
Our staff were a lot happier because of it. The introduction of the labour agreement was revolutionary for us. Even though we're in a city, we are actually on a very small peninsula, and none of our staff actually come from the local area. So we had some very loyal staff that were on short-term visas. They were students and working. And our primary aim of entering a labour agreement was to actually reward those staff that had worked for us for a long time and enable them a pathway for permanent residency and a pathway to work full-time. And so that actually increased our full-time quota of staff. It made really, really happy, grateful staff, and it made staff that had less pressure in life. They didn't have to pay for private insurance and for private school fees, and they could focus on the work that they were doing. Whereas the pay rise was great because it was really welcomed. I don't think it changed our staff profile or the way we worked at all.
Yeah, okay. Thank you very much. I'm Senator Ruston.
Thank you. Can I just unpack AI? I knew it was going to happen. I have many others that aren't AI. But no, I'm just interested in this whole piece around innovation, and you know, we hear innovation as a rhetoric, but you know, I wonder whether there is really much in terms of levers within the system to incentivise innovation. And you've clearly made a quantum leap to decide that you think the investment in AI is something that's going to be, you know, an amenity that clearly your residents like. But if you're doing that, so then we've got a mandating, like a really blunt mandate on care minutes. You've got to have X amount of registered nurses. We've basically thrown out in allied health enrolled nurses and lifestyle, that doesn't count. And yet you've made this decision. So I'm just wondering if you have a view about how we can actually better incentivise the opportunity that's offered by innovation, and whether it be AI or other innovations, to deliver a better outcome for older Australians than this sort of like blunt one-size-fits-all, you've got to have that. Do you think we can deliver a better outcome for Australians if we move away from that and allow greater flexibility in terms of delivering what each individual wants?
It's a fantastic question, Senator. Thank you. Our concern around the Act is that it might stymie people a little bit. So we are really lucky to innovate, and part of the reason why I'm here today is to show the parallels of where we can be and where we are at the moment. So the larger body of providers, we're really lucky because we have other income sources, and that's afforded us to do what I think every provider wants to do, and that's to actually go out and innovate and use technology and build new buildings and provide better care and have higher staffing ratios. It's really hard to do without the capital, and so I think because of that we've been able to innovate. We've also got a fantastic, robust professional board that encourages innovation. And they see that because we are in this really unique, really lucky position, that our job is to go out and encourage other people to innovate. And so we drag people into our facility and teach them about the different things that we're doing, some of which work great, some of which we're still working on. But actually getting out there and collaborating is a really good thing. But there's not a massive incentive for people to work outside of the boundaries of the standards. We don't learn that.
Can't afford to work outside the boundaries.
No, well, we don't actually learn the standards, so we don't teach our staff the standards. I know there's 8 standards. I couldn't exactly tell you what they are, and I'm in charge of the standards. What we think we're in charge of is really, really great care. And so,
on our way to see you.
Just came not that long ago. So we really think that if you provide really, really great care and services, and you're doing it within the framework of the Act, then you're going to comply with the standards. And the Commission is coming around to this as well. I really feel in a lot of ways that they're actually changing, becoming a little bit more collaborative. Probably my colleagues will kill me for that, but I think I think that we have to stop thinking about this very, very strict framework. Support at Home is putting in a strict framework, but in some ways I think it has to have those frameworks so that we can deliver a sustainable system. In residential care, there's so many different opportunities for change. We're eternally annoyed by the care minutes because I'm a registered nurse. Our residents don't really want more registered nurses. What they want is lifestyle, they want activity, they want rehab, they want all the things that are not afforded through care minutes. And so when you actually look at the star rating, we don't do that well. We have 24-hour nurses and we meet our mandate, but we're not willing to go above that because we want to put our resources into things that residents really care about. And for us, that is having a fairly extensive lifestyle and allied health program. And again, that is completely and utterly cross-subsidised by our commercial amenities. So.
Okay, so can I just move to that?
Yeah.
Do your residents know that they're cross-subsidising?
Yes. We communicate that a lot. So we have, our residents have higher demands, I think, than possibly other organisations because of the physical environment they're in. It's very nice physical environments. And because they're paying large RADs. And so there's this disconnect between care and accommodation. And so they really struggle with the funding between care and accommodation. They feel that they've paid this great big amount of money, which they have done, and so that should then translate to care. Now, unfortunately, in the existing Act, there is not that disconnect, and this is why we like the new Act, because there is this move away so that there is accommodation and care services. So we're really looking to communicate to our residents that they are very two discrete, two finite concepts, and that we are constrained by what we actually provide because of the existing funding system, and that we are actually supporting them. So we communicate that loudly and proudly.
So on the basis, if we just go to accommodation for a second. So what's your breakdown, RAD to supported?
So supported residents, we've got just under 40%.
Okay.
So 30% we actually call our charitable residents. Of the remaining residents that are non-supported, 90% pay a full RAD.
Okay. So
the remainder generally are only residents, fairly new residents, testing the waters until they decide. Okay. So we don't put any boundaries on our residents about whether they pay a RAD or a DAP or when they pay it. Yep. So they generally relinquish assets to do it.
Okay, so you've obviously got quite a unique funding model
Yeah.
here. I don't think anybody else would say they've got
No.
100% DAP. In fact, I'm sure I can hear every provider around the country hearing you say that and cringe with envy.
But this is sorry to interrupt. This is why we're keen to speak, because we see that the RAD retention as being a really good thing. But it's not going to be the panacea. It's going to be fantastic for us because we have lots of people that pay RADs. But there are a lot of providers out there that don't have that, and we've heard from them today that are not going to benefit from that.
I'm going back to this cross-subsidisation issue here. So you meet your mandated ratios, obviously, by the amount of supported residents that you have in your homes. So, I mean, what's your average RAD?
Average RAD, I think, is about just under $900,000.
So you're pretty much all exemptions?
Yes.
So that means that
all.
the amount of... So if you look at the value of that capital opportunity, I mean, I'm sure you're probably getting 5% or somewhere thereabouts, on an average of $900,000 for 90% of the people. I mean, that is a significant amount of return, which allows you to do what you do, and then you pop your 2% on top of it. You're right at the top end of this.
Yep.
So how does your mandate in terms of your corporate culture and charter reconcile the fact that the government is only paying you a minuscule proportion of what the rest of your residents are paying for your supported residents? I mean, it just, you say that your residents know, but does one of your residents, if a resident was on a DAP as an example, on a $900,000 RAD, that's a serious amount of money every week.
Yeah.
Are they okay with paying that, $80,000 a year, knowing that you're only getting $24,000 from the government for the person who's supported?
No, they don't like it. So, and regardless of wealth, people have an expectation that aged care will be paid, and this is cultural and historical and unsustainable, and we know that it's unsustainable. And I think this is why this bill is so important, because I think it's going to increase sustainability. But
it's going to bill the cat on that, though, isn't it?
Pardon?
It's going to bill the cat on the subsidisation.
No, that's right. But fundamentally, people feel a little bit aggrieved by it. So I think having the separation of care and accommodation, and a relinquishing accommodation so that people can pay what they can afford and what they're used to, is really, really, for us, an important thing. So it is about giving people choice, and then actually having those frameworks that you actually protect people that have less.
So do you... one of the things that I found sort of incongruous in the report, the task force report, was on the one hand, the financial sustainability and bankability of the sector was being predicated on the 2% RAD, or a RAD retention. They didn't say 2% subsequently. I think that's where the government's landed. Was on the RAD retention. But in the very next paragraph, it said, and we're going to phase out RADs by 2035, starting off with a review in 2030 to get rid of it. I mean, how does an operation like yours maintain, obviously, a absolute first-rate operation and offering to your people, if you're sitting there with a cloud of the RADs are about to disappear? Your model no longer works.
Yeah, and I think an organisation looking to get capital will become unbankable without that clarity. So luckily 2035 or whenever it is a fair way away. But it means the models will fundamentally have to change fairly significantly, and our funding model will need to change. This is why organisations have an increased reliance on additional services, and they also have an additional reliance on diversity. The traditional residential aged care facility needs to have something else to become sustainable. This is our belief.
Yep. So can I take it from that you're saying that if you got rid of the RADs, you would need to there would need to be the provision of another mechanism by which the individual had the choice of being able to use a lump sum product in order for them to be able to...
Yeah, absolutely. It needs to turn like a traditional real estate transaction.
Yeah. So just as I mean, you probably be a different answer, but do you know what it costs you to run a room?
We know that it runs at a loss, so...
So in terms of a loss, so you've got, obviously, it's the cost of capital, your depreciation, operation, maintenance, etc. I mean, anything that's not clinical care or everyday living, whatever, that goes into your accommodation bucket. So you're saying, even with the return on investment that you get from your RAD pool, that is insufficient for you to operate that room but the bank obviously likes you because they're saying you're bankable.
Yes. So we are, when we actually look at an operating EBITDA before we actually put in other funding sources, we do make losses. And our board is okay to do that because we actually have those supplementary incomes. So as a charity, with an aim of just providing the best care that we can, we know that at the moment the only way that we can do that is to run at a loss, but then to try and supplement that in other ways. Now, our income, so our income from interest is substantial now, and so that is now making us profitable. So,
would you be profitable if you were being paid the cost amount for your supported residents in terms of the supplementary accommodation or the supported accommodation supplement?
I couldn't answer you that. I don't know, is the honest answer.
Okay.
Senator Pratt has some questions as well. This could be the last one.
Oh, okay. I was just wondering whether you had a view around the requirement that's now in the Act in relation to the supporter and representative, but I think the representative has now been taken out, but the supporter provisions in relation to the duplication or complication in relation to existing provisions around a power of attorney and the like from state and territory jurisdictions?
Yeah, we are concerned about it. So we don't quite understand it. So we're looking for a lot more clarity around how that is actually going to work. As you know, every state has different rules. WA is murky at the moment, so some clarification would be really great. At the moment, we have a cascade of authority, which is quite murky and sometimes a little bit unfair. So we would like some clarification. So we think it's actually a good thing that it's in the Act, as long as it's not duplicating and creating this onerous environment.
Thanks, Chair.
Thank you. Senator Pratt on teleconference.
Thank you, Chair, and thank you to our witness. I wanted to ask, with respect to your use of AI, I was really pleased to hear about those innovations. I wanted to know how, in the future, such technology might be embedded in reporting so that organisations can equip their care standards with kind of ongoing monitoring and tracking for more automatically generated data, and also the significance of getting people to waive their privacy. I think more and more people are going to be willing to do that, and that I note that in some instances providers have used privacy as a reason to not have disclosed information about complaints, etc., to family, and the extent to which people are now providing more ongoing waivers for specific things, or also perhaps, just as my specialist did on the at my appointment today, just a recording of important conversations between residents and staff as well, so that, you know, those kinds of things are on the record for ways that can be useful in the future.
Thank you, Senator. That's a great question. Yeah, it is a bit of a minefield, and it's something that we've had to spend a lot of time embarking on. Part of it is the privacy of our residents, but part of it is also the privacy of the staff and the people that actually visit our homes. Yeah. And so we do have facial recognition technology also at our front doors, so that we don't have to keep them locked. And we do actually ask people to sign in. When they actually sign in, they actually sign a disclosure knowing that they're going to be recorded. we don't record voice, and we don't actually have access to the video content unless it's actually specifically requested by the resident or their representative. And then there's quite a detailed process that is actually outside of our hands to actually then access that video material. So in a lot of ways, this was a thing that actually gave residents that assurance, because we know a lot of residents actually have cameras, or families have cameras in aged care. We think that it should be used in a controlled manner, and we think to protect everyone's privacy. And so there is quite a detailed consent process where people must explicitly give consent to actually use the technology. But then if there wasn't an incident or a concern, that all parties involved would then also consent to actually access that data. It's something that we worry about a lot, and we've spent a lot of time actually making sure that we have lots of ticks and balances.
And what can government do in the context of this being, a fairly, you're at the forefront of implementation of something that will become more and more common? What's important from a government point of view? Can we, for example, ensure that records are in My Aged Care and that you don't have to save them directly to your servers? Or what kinds of things might help in the future to kind of universalise the capacity to do this in a meaningful and just way?
I think cybersecurity is probably key to this discussion, and I think the government has actually made I think they've actually had great successes in terms of the digital authority and the communication of cybersecurity. I think that for any provider, we store an awful lot of information about people. And actually making sure that providers are actually complying with the Essential 8 and actually having frameworks and security systems in place is super important. I think that actually bringing that into the standards would actually be a really positive thing, because we are being asked to store data, we are being asked to share data. It also makes sense that we should be asked how we're protecting data of people as well.
Thank you. And how much of this information is currently in My Aged Care in the same way that data and information is starting to grow inside My Health Record, for example?
My Aged Care is used so sporadically. So we're one of the early adopters in the trial of My Aged Care actually integrating with our care system. And we are eternally frustrated by My Aged Care because public hospitals in WA still don't upload data. Lots of GPs don't, lots of practitioners don't. So we don't get a lot out of My Aged Care other than some preliminary.
Or My Health Record clearly at this point.
Sorry, My Health Record. Sorry,
Yeah, I'm very mindful that growth in the upload of data in My Health Record by state government and practitioners will help aged care providers.
Yeah.
And equally, data from aged care providers into My Aged Care in the long term will help people in their health outcomes as well.
Yeah, I think having standards around record keeping would be fantastic, so that providers could share information. So actually having an aged care record on My Health Record, not My Aged Care, would actually be beneficial when people are transferring in and out of care. I think actually storing data on My Aged Care, I'm going to get caught up on that, will be tricky. The system is difficult to navigate at the best of times, and I actually think that that sharing the data in a wider field could be dangerous.
Thank you, Chair.
Thank you.
Thanks, Senator Pratt. Thank you very much, Mr Cox, for participating in our committee's process and for travelling here today. We really appreciate your evidence.
Thank you. Thank you very much.
And, very interesting. Okay, we'll now be moving to our final panel for the day, and I call representatives from Uniting Communities and Boneham to join us at the table. All right, thank you for appearing before our committee today. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you all. For the Hansard record, could I ask you each to please state your full name and the capacity in which you're appearing today, and we'll start with Ms Watson.
Yes, so Sarah Elizabeth Watson, and I'm here as a representative and the Executive Manager for Uniting Communities.
Great, thank you. Mr Filsell.
Yep, Mr Michael Filsell, I'm the CEO of Bonham Aged Care Services.
Great.
And Joanne McGregor, and I'm Director of Care at Bonham Aged Care Services.
Excellent. And do you have opening statements?
Yes.
You do? Yep, Ms Watson, please proceed.
Yep. So firstly, I'd like to acknowledge the Bangala people as the traditional custodians of the lands on which we are meeting and pay my respects to elders past, present and emerging. Thank you for the opportunity to appear before the committee today to discuss the Aged Care Bill 2024. My name is Sarah Watson. I am the Executive Manager for Community Aged Care and Disability Services with Uniting Communities. Uniting Communities currently provides support for 650 home care package recipients, 1,800 Commonwealth Home Support Program clients and 191 residents across 2 residential homes. My role provides executive oversight over our home and community services only. Uniting Communities is a member of Uniting Care Australia, which is the national body for the Uniting Churches Community Services across Australia. Uniting Communities welcomes and supports the successful passing of this bill through Parliament. Uniting Communities supports a rights-based approach to aged care, and we actively support the rights of older people to participate in their communities and live a life filled with dignity and respect. And embedding a rights-based approach to a new Aged Care Act is welcomed. An area for consideration is the amount of time providers have to transition into the new arrangements, in particular the introduction of the Support at Home program. This is a significant shift for both aged care recipients and providers. Without the rules that accompany the new bill, providers are not in a position to undertake any detailed planning for this, as they don't have the sufficient information about how this will be operationalised. We understand that high-level pricing information will be released in November, with more detailed information due in February. However, that only leaves a short period of time until the new model is due to be in place. The change management piece required to implement these changes will also be significant. The impacts on our client management, financial, ICT, HR, quality, marketing and training systems will require a significant change piece with our staff and the older people that we support. With less than 8 months to implement the required changes, we are yet to have all required details, including pricing arrangements, to support the work that is needed to implement the changes. A significant amount of communication and education will also be needed to support older people and their families to understand the changes. We recommend that either a phased approach or a 12-month extended period of time for the transition to ensure providers have sufficient time to implement the required changes to ensure success and confidence of the new system going forward. Another area for consideration relates to the grandfathering arrangements. These will mean that providers will require to be working in 2 systems for many years, adding additional administrative burdens and costs to maintain separate systems. We recommend a 3-year period for older people, a 3-year period to transition out of the current arrangements. Thank you, and I welcome any questions.
Thank you, Ms Watson. Mr Filsell or Ms McGregor?
Yes, no, thank you, and thank you for the opportunity to present here from the southeast of South Australia. It's a privilege to represent Bonham Aged Care Services and the wider Millicent community. Bonham Aged Care Services is a provider of 22 independent living units and a 90-bed residential aged care facility located in Millicent, South Australia, 400 kilometres southeast of Adelaide. Millicent is a township of 5,000 people or thereabouts, nestled between the coast and the Coonawarra, with logging and farmlands surrounding the area. Bonham Aged Care Services over the course of 60 years has grown to be the largest employer in the township with 188 employees and second largest employer in the area with only Kimberley Clark Paper Mill exceeding ours. I would like to start by acknowledging that regions are different to each other and certainly different to metropolitan Australia. We suffer from the term thin market quite often, which seems to cover every potential disadvantage we face, from staffing through to goods supply, housing prices and contractor waiting times. We exist to serve our community and to allow our vulnerable community members opportunity to be supported, to live their lives surrounded by their families and friends. Bonham Aged Care Services has a dedicated volunteer board of 6 members, an extremely passionate executive and a wonderful staff group. We are proud of the work we do. We recently received 5 stars for our resident consumer experience, which is the core reason why we come to work every day. We are 100% occupied with constant inquiries about rooms and units. We celebrate a break-even budget every year as an indication that we keep our service existing. When I first started in the role of CEO some 5 years ago at Bonham Aged Care, I conducted a survey of residents asking why they entered our service. As a clinician, I assumed the answer would be one of deteriorating health, perhaps acute or degenerative in nature. But close to 70% of respondents to our survey indicated the number one reason was security. They weren't secure in their own homes. Loneliness, fear of falling, poor vision, self-care deficits, all were secondary to security. I like to imagine that the existence of Bonham gives the wider community security that if ever the time should arise that they need us, we will be there. Do I believe that the new Aged Care Act should be endorsed as an umbrella to our industry? Yes. The reason I form this opinion is through blind faith, that in the 30 years or thereabouts since the last Act, I am sure that many a smart person has put their minds towards a better indication of what we should achieve with our services. Following a Royal Commission and a pandemic that nearly took us out, I feel that the task force recommendations are probably the ultimate accolade to our future sustainability. Thank you for your time and happy to take questions.
Wonderful. I'm going to start with Senator Ruston.
Oh, I get to go first. So can I just, thank you both for being here. In your submission, Mr. Filsell, you make a comment on in relation to grant funding and the difficulty of the certainty around your financial viability of your operation on the basis that you're constantly having to seek grant funding. So in terms of the capital works that you do I assume that you would require ACAP funding in order to support you if you wanted to do additional capital works for your facilities?
Yeah, even to the point of major refurbishment.
Yeah.
As I said, we break even every year, so we don't bank depreciation.
Yeah.
All of our funds go on operations.
Yeah, okay. Well, so is there something that you would like to see as a better mechanism in terms of being able to, because you make the comment about rural, regional, remote, and they're 3 different things, I get that,
yes,
as opposed to metro, that there would be a better mechanism that would provide that equity proposition, bearing in mind the implications of shallow markets and distant markets?
Absolutely. Look, we, as I said, we spend all of our depreciation on operations every year. Grant funding rounds come around few and far between. The last modified Monash Model 5 to 7 grant funding round was oversubscribed 10 to 1.
Are you 5?
Yes, we're 5 just. Yeah. So
because Narracourt's 4.
Narracourt's 4.
Yeah.
So the annex caught them up with the latest changes, which is handy operationally. But from a modified Monash 5 perspective, we do have an operational advantage. Have done since the annex came in. From a capital perspective, with the oversubscribing of the grant funding round 10 to 1, we didn't put a grant in. It takes us approximately $35,000 to $40,000 to submit a grant to get planning to a point of being shovel ready with master plans and surveys and council approvals. So we pulled back on that. We are now looking at revisiting that with the potential new funding being brought to bear through the new Act. But with a 1 in 10 chance of success, it's still a gamble.
Yeah, absolutely. You also make commenting around the registered nurse requirements and 24/7, and we heard about this earlier, that it was a big challenge in non-metropolitan markets. I'm just wondering if you'd given any thought to how you would go about fixing that. I mean, bearing in mind, obviously, the quality of care that we're providing older Australians, but at the same time, their choice and control about where they want to stay, if they want to stay in their own community. Have you any thought about what sort of innovative models of care could be applied to that so that you could still provide your older people in your care the dignity and support that they need, but at the same time, allow them to stay in their own community and not be sent off somewhere hundreds of kilometres away?
We've run our service for many years on a mixed model of registered nursing and enrolled nursing and care staff, allied health staff, and the clinical outcomes for our residents, we assume, haven't suffered because of those models, those traditional models. We've been faced, obviously, following the Royal Commission and the implementation of the mandated minutes for registered nursing to reach a certain threshold of registered nursing, are now a 1 in 10 EN capacity, so we get 10% of the funding or care minute allocation for registered nurses moving forward, and the care minute targets. It's been difficult for us. We've relied on agency quite a bit to maintain levels of compliance.
You're still using agency now?
We're still using agency. We are converting agency to regular staff. If after a period of time of regular agency shifts they want to move to Millicent, we will facilitate that. I've just had an invoice from an agency to transfer a staff member over to staff. There's a contractual obligation to do that when they decide to take up permanency with us. From an innovative model perspective, and I may hand to Joanne here as our Director of Care, we still feel that the enrolled nurse would be a more valuable asset than 1 in 10, or 10% of our registered nursing. Potentially a modified aged care nursing career pathway as opposed to just the registered and enrolled nurse acute care pathways that have existed in the past to satisfy the market and satisfy the need for compliance. Beyond that, I mean, things such as telehealth and medical intervention, all sorts of poor cousins to face-to-face assessment and interaction at a clinical level, I believe.
Yeah, absolutely.
Joanne, would you like to comment?
Yes, thank you. We fully support providing quality care through the nursing minutes, and we've considered multiple options and actively looking for new opportunities all the time. As Michael said, our township is 5,000 people. We have a medical centre, a hospital, another 45-bed nursing home attached to the hospital. We have community services in the community as well. And Mount Gambier's half an hour up the road, so we're competing with staff who are happy to travel to Mount Gambier for work. We believe that we have opportunities through using ACPA's graduate program for both registered nurses and enrolled nurses, and although we haven't had any applicants yet, we're actively looking at opportunities to support people who want to come into aged care, or some of our enrolled nurses who are currently converting or studying to become registered nurses and wish to come back into aged care. We do use agency staff, but agency staff are a bit like Forrest Gump's box of chocolates. You don't always know what you're going to get. And having a registered nurse just for the sake of having a registered nurse doesn't necessarily result in delivering quality services to the residents. So growing our own, supporting our own, looking at opportunities to attract and keep our own through flexible rostering, and perhaps using the opportunity to use more enrolled nurses alongside the registered nurses, we see as an opportunity to pursue.
Do you do home care as well as resi care?
No, purely residential.
Resi care, whereas you do. So you made, Ms Watson, you made some comments earlier on about your concerns about the timeframes, and you were quite strong in your concerns around the lack of information in order to even start the process.
Yep.
So do you have a view, once you have all the information around what is actually going to be required, particularly when it comes to the supported home program or the home care more generally, how long it would take you to get your systems in place once you knew the full details of what was required?
Yeah, look, I think from, best guesstimates, at least 12 months. I think, looking at, if we just look at system configurations with a client management system, getting vendors on board, undertaking scoping works to make sure all the configurations that go through our rostering system to our finance, the interfaces with our payroll systems, it takes a significant amount of work. So, and that's just one small component of it. There's a larger training of our staff that also has to be done. And also the communication with our clients and families around what some of those changes will mean for them, and working with our consumer advisory group as well to get their input around what would actually make sense for them. Often the discussions that we have with our consumer advisory group is the lack of clarity in the current aged care system. Introducing new changes to that is going to be quite challenging for some people, so making sure that we've got all our communication in accessible formats, where we've got English as a second language, we've got low literacy skills, how do we then make sure that we're providing the best information in the most accessible format? So it's a large piece of work and we want to get it right. I think that's the key thing, and I think, for certainly us as a provider, we can really see the benefits of this, but we want to get it right and we want to build that confidence and trust in the people that we support, and really ensure that we can do whatever it takes to make sure it's working. And unfortunately, we just don't have the details to do that. We've as an organisation, we've certainly been, attending and listening and reading about all the information that we can possibly get. A couple of weeks ago, when we had a little bit more detail, that was really helpful when the Department of Health, provided some more granular detail. But we need more to really make those system changes work for us, so we can implement the new model well.
Yeah. So have you had any idea, when you think of the kind of costs that will be associated to your organisation for making these both systems changes and the training requirements?
Yeah, so look, rough estimates, just for training. So if we're looking at, say for 300 people, average of $40 an hour, 10 hours, there's $120,000 just in itself. So, and that's just one small component. Updating, the configuration to any systems, it's going to be a lot more. So, I couldn't give exact costs, but we're talking a lot of money. Yeah,
absolutely. So, my favourite question, RAD supported resident accommodation supplement.
Yes, I have the figures here for Bonham. 90 beds.
90 beds.
90 beds. 13% or 12 DAPs.
13%.
13.
DAP.
DAP.
Yep.
Or 12 residents.
12 residents.
90. Yep.
RADs.
RAD full deposit. 33%.
Yep.
29 residents. Partial deposit, so RAD DAP mix. Yep. 11. 12%. Partially supported. Concessional 24%. Fully supported 18%, which gives us a 42% supported ratio.
Yep. For supported. And what's your average DAP, RAD?
So our maximum RAD's 440.
Yep.
Our average full RAD is 375. We don't charge the full. The overall average RAD is $278,000.
278.
Yep.
So that's significantly lower than the
900,000 that we just heard.
Great envy sitting there as you
Horses
heard that.
for courses, yeah, that's right.
I'm sure his build was more expensive in the first place. So I'm just interested in terms of your capacity to operate your rooms on the basis of the funding model, the range of funding that is provided to your organisation. If you just take the accommodation component out of what you're doing, are you able to break even?
Yes.
Okay. And ANAC's okay?
Operationally, we get a kit being modified Monash Model 5.
Okay.
So, and we're over our care minutes, so we spend that
okay
in advance.
So, so what is the basis? I mean, like we hear often that there are like if you took full care minutes into account, we're probably still talking about 2/3 of Australia's RAC is operating unprofitably. You're operating in a Monophate Monash 5 with very low RADs and DABs, and you're still profitable. What's your secret to success?
Prior to coming on board, there was a doubling of the size of the facility with a zero real interest loan, which sits. So zero real interest loan is
free money.
Well, it's an oxymoron. It's a CPI loan basically, so a hedge against inflation. So we still pay that back, both principal and interest, on a monthly basis. That was set to double our size. So I guess our scale has improved. So we're still holding that legacy, and we apparently churn through a great deal of our RADs. So to build the extension on the facility. So that was a risk taken with previous board and management, which we've operated our way out of. As I said, if we're cash positive, we haven't been banking any depreciation because the facility was relatively in a good position in terms of its refurb 10 to 12 years ago.
So in terms of your local community, do you have a waiting list to get into your home?
Yes.
Yes, I would have between 3 and 7 inquiries every week.
Every week?
Yeah, and we do confine ourselves to offering accommodation to people from the local area. We have inquiries from outside the area, but we see ourselves as having a need to commit to the local community who don't have a lot of resources available to them in terms of residential accommodation, really between Mount Gambier, Millicent and Meningie. So we consider those applicants as a priority unless someone outside the area has a family or a genuine reason to relocate back into Millicent. So when a bed becomes available, I always look at the room that's available, because our rooms have been built over time and are all slightly different. So look at the room that's available, the population of residents in that particular area, and the needs of the people who are waiting to come in, and we offer the most suitable room to the person in the greatest need.
We heard evidence earlier this morning that from some providers here in Port Lincoln that they were seeing, because of the demand in Port Lincoln for beds, that the hospital was often contacting them to see if they had a bed, and if they didn't, they would have to move somewhere away. Are you experiencing that in Millicent as well?
Yes, we are. We've had, as recently as about 8 weeks ago, we know that Mount Gambier Hospital had 29 people waiting to transfer out to aged care. Our local hospital contact us regularly. As I said, there's another 45-bed nursing home attached to the hospital, and they do take some residents as well. I find the resident group that we are not able to meet the needs of at the moment are people with BPSDs who have not had a psychogeriatric assessment, and whose aggression is such that we're not able to safely accommodate them within our facility.
Yeah, that's a whole another issue, isn't it?
Yeah.
Yeah. So, sorry, bouncing around here, Ms. Watson. In terms of the changes to support at home and the pricing, just interested if you had any views that you'd like to put on the record around the robustness of existing pricing that in home care, and your confidence of the ability to get an efficient price that is even remotely realistic, and what you'd like to see done to create it.
That's a great question.
Your horrid look on horror on your face.
Look, I think also having experience within the NDIS as part of my portfolio as well, we having the pricing list basically. I think the efficiencies and what that actually looks like is going to be incredibly important for the sector. I think, if it's if we don't get that right, or if it's not done where it's viable in the long term, we will see providers, have to make some really tough decisions. And, we do have, talking about thin markets previously, especially in regional remote areas and rural or very remote, that is always a big concern. But I think for even providers in metro, knowing, how we have the pricing in addition to all the quality components that we need to do. And you talk about innovation as well, and then trying to do innovation on top of that. It is a really significant issue, and having not yet, got the pricing from, and seen what that looks like, is concerning, because there needs to be a lot of work going into that to see what that looks like going forward, and how we need to create our own efficiencies within the organisation. So again, that takes a lot of planning, and we need to have more detail around what that looks like sooner rather than later.
Have you, in the small amount of the rules that we've seen so far, in terms of the categorisation and price list for that, there seems to have been a decision that's been taken to reduce the maximum amount for care management from 20% to 10%. Have you got any? Did you have any consultation? Have you got any idea what the decision making around why that occurred?
No, I don't. I don't know whether that's something that maybe other areas, ACPA or someone else. From the Uniting Communities perspective, no. And I think having that and the package management then being rolled into the overall pricing or the unit costs, again, is a concern, because it's the basis and the structure of how we actually do things, how our quality systems work as well. So again, we really need some information, but in answer to your question, no.
Yeah, so, because we have heard quite a lot of concern around the impact of this. So, from your operational perspective, like what would be the impact if 10% was the cap that you was put on your care management services? How does that play out to the person that you're looking after?
Well, we have a lot of people with varying degrees of support needs. We have some people currently who are on a level 4 who probably have, depending on their level of, family support or other connections, versus some people who, maybe on CHISP or level 1 packages, so those low level supports, who require a lot of additional support as well. So, not sure. In short, it's going to be very difficult to determine, and I know they're talking about that pooling of money, but it's going to be really difficult, and which is why we want to see the pricing schedule out sooner rather than later, so we can do what we need to do to ensure the viability going forward, and set up our systems in a way that we can ensure that, and provide the quality of care that's also needed, because when the efficiencies are there but the quality's not, that's not a great thing either, and as an organisation, the quality side of things is the most important, but if there continues to be a deficit of doing that, ultimately there does need to be some decisions that need to be made. So we're really hoping that the price efficiency is reasonable and it is viable going long term.
So how many people do you look after that are on CHSP and how many are on HCP?
Yeah, so currently approximately 1,800 for CHSP, that's across the state, and about 650 for home care packages.
So what sort of transition time do you think you need? Because obviously some of those people that are on CHSP are on CHSP because they're waiting for a package.
Yep.
But others just need the services that CHSP would offer. How long out do you need some greater clarity around what's going to happen to CHSP, because at the moment, from looking at the bill, I can see nothing that deals with CHSP at all. So what sort of timing do you need, and how are any of your CHSP residents or clients concerned about the fact that they haven't been picked up in this, or is it not evident yet?
Look, I don't think it's probably evident at this stage. I think from a provider perspective, because we're living and breathing this on a day-to-day basis, and sitting on the webinars and reading information, we're certainly more immersed in this. Whereas our clients, they're getting on with their lives, they're doing their day-to-day stuff. So the understanding or the I suppose recognition that something might change isn't really there, and this goes back then to the communication and education piece that's required around, we've started in the last 12 months putting out our client bulletins and newsletters to, start providing those information. But at the moment, there's, I suppose, a little bit of, they're not aware as much of what's actually happening at a larger scale.
And can I just one last one? I know because the chair's she starts nodding at me.
You can feel me. It's a silent language.
In the bill, there's reference to supporters, and interested to understand whether you think that that is necessary, or is it likely to create a greater level of confusion, given the existing provisions in relation to power of attorney, etc., that exist, well, in your case, under the South Australian government legislation. Have you got any concerns around those supporter provisions? And if so, maybe you could, enlighten us on what they are.
Change management's always a concern. I think imparting that on the cohort that need to know about that. We've got provisions in place already that have worked adequately for a long period of time, but obviously there's some change necessitated there. From my perspective, I'll be taking legal advice from our providers regarding how that transpires within South Australia and how it intersects with the current legislation moving forward. But it's a concern because of the overlap and the change.
Okay. Thank you very much, Chair. Thank you.
Thank you. Senator Pratt has some questions joining via teleconference. Senator Pratt.
Thank you. I wanted to ask with respect to the boost in wages for aged care workers and how important that has been to your organisations in service delivery and staff retention.
Did you want to go first?
Yeah, sure. Look, absolutely, it was welcomed by the staff, and I don't think we've probably got any data to suggest that it has increased retention. Certainly, they're a lot happier with the increase. So, yeah.
Our retention rate has increased as a result. We're not competing with other entities as much, such as NDIS and the local hospital for various staff. We run a grow your own program with traineeships, what have you, which is very successful in terms of care retention. We're well below the national average in terms of turnover. So, yeah.
So that's what I take from that is that boost coming before these changes is pretty fundamental to its eventual implementation and it being deliverable.
Yes, and the fringe benefits are things such as not having to rely on care staff that are from the agency and what have you at an increased cost and less of a result for our residents in terms of their interaction. So it's been a positive for us particularly.
Thank you for tracking that and giving us that advice. Thank you. Thank you, Chair.
Thank you, Senator Pratt. I believe that concludes questions from senators online as well. So I'd like to thank you all for appearing before our committee today. We really appreciate the time you've taken to appear before us to provide your submissions and to give evidence. I don't believe you took questions on notice, but in the event that you did, we're asking for those to be returned to us by close of business on the 21st of October, and that deadline extends to other witnesses who may have appeared today who wish to provide supplementary information. That is the date we would be seeking it by, to enable us to report on the 31st of October. But that does conclude today's hearing. Thank you for all the witnesses who appeared, to Hansard and Broadcasting, as well as our Secretariat for your assistance. We will be holding our next hearing for this inquiry on Wednesday in Newcastle, but until then, the committee stands adjourned. Thank you.
Thank you, Chair. Thank you to our witnesses.